meeting of the Health and Wellbeing Overview and Scrutiny Committee. Just gonna. Is everyone in? Yeah. I'd like to remind everybody present that this meeting is being live streamed to the Council online webcast channel. I'd like to also remind members of the officers to mute their microphones when they're not speaking and to use the raise your hand option when you wish to speak. I will give everybody an opportunity to speak at the end of each item. Can I ask all mobile phones and other electrical devices and TV and tablets to be muted or turned off and to be silent during the meeting? Okay, thank you. Okay, first item on the agenda is absence and apologies. I have received one from Anthony McKeever. He's due to us going into lockdown now. He's very busy at the moment, so hopefully he'll be able to update us regularly through the system. And it's rather loud. Okay, anyone else have any apologies? Anyone? Jenny, is there anyone more? No?
No, Councillor Rav.
Okay, thank you. Okay, moving on. Right, minutes. I move the minutes to the Health and Wellbeing Overview and Scrutiny Committees held on the 3rd of September to be approved as a correct record. Does any member have anything to disagree on this? Okay, Councillor Mardoni.
I think Councillor Holloway was there first.
Oh, thank you, Sarah. It's okay. You can go first. Thank you.
Sorry, Councillor Holloway, I didn't see you pop up.
No problem. It's fine. I don't mind going after Councillor Maldoni. No problem.
Thank you.
Hello. I just wanted to raise in the minutes. Obviously, I brought up last month about the £480,000 that's owed to Thurrock. And I also asked a question to the portfolio holder in the chamber and was told that we were going to receive a paper at some future HOSC meeting. Well, I know we haven't received a paper, but I see that there's been a letter which has been circulated, which I just wanted to clarify. Does this mean that we're not getting this money paid back?
Yeah, thank you, Councillor. Like you, I think the letter almost stated at the bottom, so therefore you're not going to get the money back. Obviously, we don't find that acceptable. Now, we will be looking at this. I will be communicating back with them. Going by that letter, I did get the feeling that they're saying that because we come under budget, it didn't affect us at all. Well, that's wrong. Sorry, it's just purely wrong. No, it doesn't. We can't say that it didn't affect us. We could have put it onto extra services and things like that. No, Councillor Holloway highlighted this last time. Now, these issues, anything that puts us back out of our budget, and there's no guarantee it's not going to happen again. That's also what I couldn't gain from that letter. So I wanted some clarification on that to say, are we or are we not going to receive this payment in, just a pure statement from them?
Well, obviously, I completely agree. It's totally unacceptable. We had a representative from NHS England here in September last year, I believe, if my memory serves me correctly. He said that the money would be paid back after a year, over the course of 3 years. I believe we got the same assurance from Anthony McKeever. So to now receive this letter, which seems to be saying, although it wasn't entirely clear, it seems to be saying that we're not now going to receive this money is completely unacceptable. So can we actually make some recommendations about what we're going to do about it as a committee? Because I don't think we can let that stand.
Yeah, I totally agree with you, Councillor. I think, we need to go with the member. I think together with us, we need to put a recommendation through for some clarity on this and to say that we do wish to receive the payment back. I do believe it is a loan, so surely with the loans attached, there is guidelines and laws that they should have to stick to as well. Councillor Hardaway.
Thank you, Chair, and I would agree with obviously what's been said on about the monies. I think it is absolutely outrageous that having been given the assurances that this money was going to be repaid, and it was used for services. And I know that it was actually specifically earmarked for mental health. And although it postponed, it delayed, people getting what they needed to get. And I remember back at the time reminding people that, the Cambridge and Peterborough, CCG is essentially like a platinum service, and the reason it's platinum because is they took our money and spent it on services. So I mean, it's just appalling. And also, what does this say about trust between us and our NHS colleagues? If we're told one thing, assured one thing, and then the next minute told, so actually no, you're not. This isn't the truth. How can we then trust what's been said going forward? Can I suggest, Chair, that we that you write a letter as Chair of Scrutiny, and even possibly jointly with the portfolio holders, or individually or together, to write back and say it's unacceptable? I would suggest if that could be kind of a recommendation. And then to my item, my question, Chair, is for the minutes. I brought up last time the absence of a vice chair. We're still without a vice chair. Still concerned, still worried about that. Can you just update me what you've done as chair to ensure that a vice chair is appointed? I know that the procedure is to go through full council, but as chair, what have you done to try and grease the wheels, so to speak, to get us a vice chair? And are there any meetings that you've been invited to that you haven't been able to attend that a vice chair might have? So that's my first item. Thanks.
Thank you, Councillor. First of all, I do think Mark Tebbs probably needs to come in on the first point of that, because I think it could be critical to the rest of my answer. Sorry, Mark. Thank you.
Sure. Thank you, Chair. Maria Wheeler, who wrote the letter, our Chief Finance Officer at Thurrock CCG, did offer to attend the meeting this evening and kind of talk us through, but was advised that maybe that wasn't necessary, but it sounds like it is. I'm happy for discussions to happen outside of the meeting with Maria. She's obviously been in dialogue with regional colleagues in drafting the letter, and indeed to kind of bring it back for a fuller discussion with the kind of right people in the room for the next meeting, if that's helpful.
Thank you, Mark. Yeah, definitely. I don't think we should actually wait till the next meeting to get the update, to be truthful. I think we should be pushing this forward to get some information quite urgently. I don't know, did you get to speak to the portfolio holder today? Mark, did you get to speak to Councillor Mays today?
No, not today, no.
Right, okay, thank you. And so going back to Councillor Holloway, your other points, just trying to re-enlighten me. Vice Chair, first of all, the Vice Chair, yeah, it's a very important thing. I'm concerned that with your leadership, your leader now hasn't jumped at the chance to put somebody as Vice Chair on here. It did not approach our leader before the last cabinet. Sorry, just tripping over my words. Full council. To suggest a full chair, to have another vice chair. Has he offered any of your members of your party the vice chair? Because it seems very lack of strong leadership coming from your leader.
Chair, I think just for clarification, it's really important that we're not the only party that sit on the scrutiny committee. Obviously, there are other members of other parties, and it's not just Labour that can nominate to the position, of course. It's up to all groups to have a look. So I don't appreciate the criticism of our leader, unfortunately. I think what's really important, however, is that we do have a vice chair. I raise this not because I have any interest in being a vice chair. I will not sit as your vice chair. I don't want to. But that doesn't mean that the scrutiny process shouldn't have one. It's very important that we do. In case that you, Chair, don't attend meetings, it's also another layer of scrutiny function. Usually it's another opposition member, and it worries me, in fact, that we don't have, again, that additional layer of security. That's why I ask you, what have you done to speak to your group leader and others to encourage them positively that they want to take up this chairship? So I'll leave that with you and raise my next point.
Actually, Councillor Holloway, I have actually approached other people,
Right.
One of them being Councillor Massey, regarding having the vice chair. Obviously, he has quite a lot of commitments. I don't know if you agree with that, Councillor Massey.
Thank you, Chair. Yes, that is a simple explanation, I suppose. I don't think I've got the experience yet in the committee. I'm still learning the ropes a lot of the time. I don't think I'd be the best person, just due to time commitments, to be the vice chair right at this moment. But thank you.
Thank you, Chair, for clarifying, and that we as a committee now understand that essentially we'll have no vice chair going forward. So my second item is regarding the minutes, is the work programme item, which I think the minutes have inaccurately captured what was said there. It says that Councillors Holloway, Muldowney and Massey requested a detailed fees and charges report. That wasn't what was requested. There was no request for fees and charges. It was, oh, and if I had, by the way, a verbal update is not what is acceptable. I asked very clearly a line by line budget options, providing the options that had been given to the portfolio holder, bearing in mind the council has to make £20 million worth of savings next year, and it's an extraordinary amount of money that is now going to go without scrutiny. It's completely unacceptable that there is no scrutiny, no financial scrutiny going on of this council at this scrutiny meeting. The minutes say the chair agreed in principle only based on the time available for officers to prepare the report. The chair didn't actually say that very clearly on the recording. He said, if it's appropriate. So I just wonder, Chair, why have you not pushed for a detailed finance report? Did you not think it was appropriate for tonight's committee?
It's actually come down to what you actually asked for and what you want to clarify for. I'm aware, Councillor, we do have some very important items on this agenda. One of them is later on, is a presentation of Roger giving you some update on the financial status of that. I don't know if you actually read your agenda, because there was that item on there. The breakdown that you've asked for, again, obviously that has more financial implications for the whole of the council. That is not something just to be discussed within a HOSC meeting.
There is no written report. I've read my reports cover to cover, Chair. I hope you do too. As you'll see, there is no detailed financial report. I just think it's atrocious that there is no financial update, and there'll be no scrutiny of £20 million worth of cuts.
Councillor
Can
Holloway,
you change the minutes to reflect the accuracy of what was said, please?
Councillor Holloway, you know what? I'll be really blunt. If your leader would like to put a vice chair in, then perhaps I can communicate with you via your vice chair.
I'm talking about finances, Chair. Finances item now.
Yes, and as I said, finance is a wider scoping commitment, and it wasn't just for this HOSC meeting to discuss. You will be getting a verbal update from Roger today, and further to that, you know it's going out to consultation, and we will get a more detailed report back once the consultation has been put out, because it has to come back to HOSC. Thank you. Okay, Councillor Muldowney, can we move this on quickly now, because we have got a tight agenda tonight.
Yes, I'd just like to come back to who was it who said it wasn't necessary for Claire Wheeler to come to this meeting to explain the decision tonight. If Mark could let us know that.
I'll come in there, Chair, if I can. So unfortunately, we received the letter after the papers had already been dispatched. We felt that it needed a more detailed report, so they're more than happy to bring it back to the next meeting. But the letter we received came after the papers had been dispatched for the meeting.
Thank you, Mark.
Roger.
I'll say, Roger. So I was looking down at Mark and you were speaking. I do apologise. Okay, moving on to item 3. Any items of urgent business? I've not agreed to any items of urgent businesses. Item 4, declarations of interest. Anyone have any declarations of interest?
Chair, I'd like to declare an interest through my employment. I'm involved in providing Thurrock Mind with ICT hardware and services.
Thank you, Councillor. Likewise, myself, I'd like to declare an interest, obviously, with Thurrock Mind of being our anger management tutor. Any other declarations of interest?
No, Chair.
Okay, thank you. Item 5. Items raised by Public Health Watch. Kim James, do you have any items you'd like to discuss?
No, thank you, Chair. Health Watch hasn't got anything this evening other than to feed into the items as we go through. Thank you.
Thank you, Kim. I'd like to add some congratulations to your awards, Kim. If you'd like to come back in and just give us a quick update of what you've received.
Oh, thank you, Chair. We, as Health Watch Thurrock, entered a bid into our Health Watch England, the national programme, for a national award. The piece of work we submitted was around the work we done last year with public health after raising that overview and scrutiny, our concerns around the loss of funding to the violence against women and girls agenda. As a result of that, we came second, highly commended, which is really good for a tiny little health watch out of 153 across the country. So we're more than pleased with that outcome, but we're more pleased with the outcome for the people concerned and the piece of work that we've now sort of secured some of that going forward, that a JSNA has been done. So our biggest, the biggest gain really was for the people of Thurrock. So we're more than pleased with what we got. Thank you.
Thank you, Kim. Again, congratulations. I'd also like to say well done to Councillor Holloway, who helped push this through and highlighted this. So again, congratulations, Councillor, as well. Okay, Councillor, would you like to come back in, Councillor Holloway?
Yeah, I really appreciate that. Thank you so much, Chair. And I just want to echo your kind words to Health Watch. So phenomenal to be rewarded for an excellent piece of work. And as you said, Chair, you know, it's a piece of work that hasn't just been left. We had a summit at the beginning of the year. You know, there's a subgroup being established with its first meeting coming up soon. So it's not just it's a phenomenal piece of work. Well done, Health Watch, and we're just really lucky actually to have your team locally to support the work of the council, support the work of the team, and to support ultimately the residents and get their voices heard. So huge thank you, and thank you so much, Chair.
Thank you, Councillor.
Thank you.
Councillor Mardani, was you going to come back in?
I haven't got my hand up.
Okay, thank you, Councillor. Okay, moving on to item 6, Basel University Hospital Maternity Services. This report can be found on page 19 to 52 of the agenda. I welcome Claire Packer to the meeting and ask if she'd like to introduce the update, please.
Thank you very much, and thank you very much for giving me the opportunity to come along this evening. You have a short covering paper, and you've also got the report that the CQC published in September from the visit that they made to the maternity unit in June of this year. I think the context for this is a deterioration in the CQC rating for the maternity service over the last year or 18 months now. And I think that obviously we are very, very concerned at the CQC findings, and we are very determined that we are going to get the service back to the high standard and the high quality rating that it had previously. It's fair to say that a great deal of improvement has been made in the last few months. One would also say that we should never have got here in the first place. I think that it would be right to point to the fact that over the last few years, I think probably over the last 5 years, the number of diabetic women using the service, the number of obese women using the service has really increased the amount of complexity within the maternity unit. And that's put, although the numbers of women delivering in Basildon Hospital hasn't gone up, the complexity of them has. And I think we hadn't really quite kept pace with that from a medical and midwifery staffing levels, and to some extent training in the advanced skills that they need to look after these more complex women. That's all being addressed, and we have invested, as you've seen in the paper, with additional midwives, additional capacity, additional consultants, and in an extensive training programme that helps the midwives in particular, but also the medical staff, to recognise when complications are arising during childbirth. I can't say that we're completely out of the woods yet. I wish I could, but we did have another follow-up visit in September where CQC did note some improvement, but they also noted that there was more that needed to be done, and certainly more to be done to embed changes so that they could be properly evidenced. So we are still working with the CQC on a regular basis. We're providing them with lots of information. I would point to the fact that I've said this in the report, that our stillbirth rates and our complex our outcomes for women and babies is still good. Our clinical staff believe fundamentally that it is safe for women to deliver their babies at Basildon Hospital, and the feedback that we have from women is that they're still having a positive experience. Now, you may have some more local examples, and of course I'm very willing and happy to hear any feedback that you personally have got from women from Thurrock. But our high level assessment is that patient experience is still good, but there is obviously an extensive improvement programme in place to try to make sure we achieve all of the requirements that the CQC have set out. I think I'll probably stop there, because I think the report and the covering paper are quite clear about the issues that we have, and certainly there's no avoiding them. You know, they have been very critical. There was also some press coverage earlier this week that you may have seen, because when they came back in September, there was something called a Section 31, which is a regulatory notice, which somehow or other got leaked to the BBC. So they ran a programme on Monday in their Look East news. I know you probably have London, and I'm not sure whether it was picked up in London as well. But I just wanted to make sure that I was being very transparent that these problems are not historical. We still have some current challenges that we're trying to manage. I'm going to open up to questions.
Yeah, I'll open up to the members first before I comment. Councillor Madani.
Thank you, Chair. Thank you, Claire, for that summary of the report, which I did read in detail. I think obviously some actions have been taken. I think my major concern still remaining is that a lot of the concerns that were picked up on this inspection that happened in June were actually also picked up in the inspection in February 2019. That an action plan was developed for that, and that was all signed off as completed by the Trust in February 2020, when they've come back in June and they found a lot of the same problems. So clearly, although the action plan was signed off, it wasn't the case that those issues were dealt with effectively at the time, or there wasn't enough time to embed. I mean, I'm not quite sure what the issues are, and I'm sure you've got a better handle on that than me, and have had to go through it in great detail with the action plan. But certainly from my perspective as a councillor scrutinising services for Thurrock residents, that is the main area of concern for me. What are you doing this time to ensure that this time the changes that have been made, and I understand that you've made substantial changes to the leadership team, which I think is right and proper, and it does seem from the report as if that is being beneficial, but obviously it needs time for that to show if it's truly effective and for those changes to be embedded. But what are you going to do this time to make sure that these changes are made for the better and stay made for the better? Thank you.
So I think you pick up some really important points there, and of course our trust board and our executive team have asked ourselves exactly the same questions. Is how can it be that action plans were signed off and assured with evidence, because we always look at evidence before action plans get signed off. And I think at some point in the future, we are going to do a bit of a look back exercise to see what can we learn about our governance and assurance processes to ensure that this kind of scenario can't happen again. Some of it is a manifestation of time. So despite, I hear exactly what you say about the 2019 report, the actions and the decisions that were made as a result of that were about the investment in £1.8 million of staffing, midwives and doctors. Now, obviously, you'll appreciate that the time it takes from making that decision, or sorry, having that recommendation, creating the business case, taking the decision to make that huge investment, getting out, recruiting. So it's only now actually that the last 20 of the midwives are coming in, because we tend to only be able to recruit significant numbers of newly qualified, and that only happens in September, October. So some of it is a bit of a lag in terms of decisions being made and then the time needed to implement. Some of it is that we put things in, we tried them, but then we've discovered actually they probably weren't achieving what we needed them to achieve, and the team locally decided to make a change. So when the CQC came back in and they said, well, you told us, for example, that you're doing your safety huddle at 11:30 in the morning, but none of your staff knew about that. It was because actually the safety huddle had been stopped. It's an optional thing, but it had been stopped at 11:30 and then was being reintroduced 2 weeks later at 1:30. So some of this type of thing, which on the face of it sounds like there's no safety huddle and nobody knows what's going on, can be relatively straightforwardly explained. Other things, I think, the amount of change that we're trying to make is very difficult to embed all of it and evidence all of it as being in place. So I think it's a real combination of things. The leadership team at the moment have got some additional help. We've managed to bring in a director of midwifery to sit above the maternity services on all 3 sites to make sure we're sharing the learning across Broomfield and Southend as well. And we've also got an improvement director in, who's a very experienced executive, who's supporting them to actually deliver and evidence the changes that are being made. There are a couple of the examples.
Thank you, Councillor.
If I can come back in, because yes, thank you, Chair. Thank you, Claire. Yes, I can see the size of the change that you're having to make here will need considerable amount of time to make that change and for you to see whether that's producing the effects that you want from it. I mean, I think in that case, I'd like to move a recommendation that this comes back to health scrutiny, perhaps in March next year, or I don't think I'd like to leave it a year, maybe March, or if there's a June or July meeting, but that we put it on the work programme to come back and to look then, just to make sure that this time we are learning all the lessons and we don't have to go through the process again. Thank you.
Sure.
Thank you, Councillor. Yes, we are going to be putting that back on there as a recommendation. I mean, I'm not going to cut back the bush on this. This is a damning report of the services of maternity. Now, we've got criticism on there from the report of staff. They're not aware the staff actually were capable or competent for their roles. We've got staff did not always complete risk assessments for each woman. These are really basic errors that I'm really concerned about. And we're talking about lives. You know, from being a joyful part in somebody's life is turning something tragic. I can sit here tonight and reel off the emails I've got from residents when they knew this was coming here, of horror stories of no maternity care after giving birth within the hospital and things like that. I'm aware that there has been another report, another visit. I would like to pick the bones out of that when that comes through. We can have a look at the report when that goes online. I am very aware of Councillor Maldini. I do agree with you that leaving this a year for it to be looked at again would be too long. So the recommendation will be a shorter period for it to be reviewed. On that note, I'm just bringing Councillor Holloway.
Thank you, Chair. I think Councillor Redsaw was waiting first. Do you mind?
Oh,
I feel a bit bad.
No, that's right. So, Councillor Redsaw.
Thank you for that. I didn't want to complain. Yeah, thank you, Claire. Yeah, just going back on a point, Councillor Maldini, I wouldn't even like it to wait till next March, because I think, as Shane just said, we could have deaths. Reading this report as I have, it is damning. you know, if I was a woman giving birth at the moment, Claire, I wouldn't feel very safe. Some of the things on page 20 when it says, however, the service did not keep pace with increasing complex demands. And then it goes on to say lessons learnt were not always implemented. And I think, you know, we can probably pick the bones of this out, but I don't think it's going to do us any good, because I just think that, as Shane just said, when you're in hospital having a baby, that's someone's life. And a little baby is coming into the world as a person. And if that, you know, it says the number of prenatal deaths is below unexpected levels, well, I'm sorry, you know, and nowhere in this report, Claire, can I find out about home births. You know, sometimes home births do work. You know, I mean, I don't want to labour the point, but I delivered both my grandchildren at home. And, you know, I think there's some respects that it can work very, very well at home. You know, but I didn't find anything to do with home births in there at all, unless I've missed something, Claire. I mean, I've got quite a few questions, but I don't think until we see some real change, which I think should come before March, because otherwise, if we're going to lose babies in between now and next March, I find that really disgusting, actually, Claire. Thank you, dear.
Can I just come back on the bit about babies dying? So the report does obviously refer to 6 babies that were classed as serious incidents, where unfortunately they'd had a difficult birth and they had to be transferred out for brain cooling. What it doesn't do is give you any context as to what happened to those babies. So unfortunately, one of them we do think that there will be some ongoing concern with, but the other 5 babies all were discharged home and are, to the best of my knowledge, thriving. So we don't believe that women are at a greater risk of their babies coming to harm at Basildon Maternity Unit. And if the CQC believed that, they would close us down. So, you know, I just wanted to make that point. It's not that they are worried that babies are unnecessarily dying in our unit, because they definitely would take a decision that it was not safe to remain open. And we do have a home birth service. I think part of our problem in Basildon and Thurrock is that our women tend to be quite high risk. So a number of women do deliver at home, and we do support that. And we have a community midwifery team that do that. But this report mainly focuses on the labour ward, where the highest risk ladies are giving birth.
Thank you, Claire. I just want to come back and say that I'm aware that this report had a start and end date of when they looked at the cases. I'm aware of cases that happened just outside that remit where internal investigations were done within your ward over death of a baby. So I'm not going to say this has only happened because what's been highlighted in the report. The problem was there before. These are just ones that have fallen into that report that appeared in the newspapers, what the whistleblower report brought out.
Well, we actually reported these cases to the CQC.
After the whistleblower?
No, we reported them to the CQC, and coincidentally and at the same time there was a whistleblower. But we tell the CQC about every adverse event that happens within our maternity unit proactively within 48 hours. So we're very, very transparent with them.
Okay.
Can I come back slightly?
Yes, sorry, Councillor.
Perhaps, Claire, there should have been something in there. I know perhaps you don't want to put home births, but perhaps there would have been some good to have gone in there, you know, to have let people know that there are, you know, you can have your baby at home, you can do things. Perhaps that would have been mitigated a little bit of what's happening, because it isn't very good, you know, even though, because in August, we're only September, October, you know, we're in November now, but only at the beginning. So you've still got a long way to go, haven't you, to implement most of the things that went wrong.
Yes, I might suggest that it might be useful if we have a future meeting, that perhaps some of the leadership of the service might want to come and talk to you about what they're doing. I think it might help to hear from them directly.
Yeah, definitely. Yeah, thank you, Shane.
That's right. I know we were invited to the hospital, but obviously due to the pandemic, we just thought it wasn't advisable to actually attend. So, but again, we do appreciate the invite. Councillor Holloway.
Thank you, Chair. Yeah, thanks for your time this evening, Claire, and coming to talk us through this. I think my usual go-to would probably be to say, you know, I'm kind of unsurprised about, you know, a service that has been under a difficulty, bearing in mind a decade of underfunding, you know, for the NHS. But that alongside this, there's very practical things that have been told to the hospital that should have been done. So whilst I'm sympathetic that funding is an issue, and I will always say that, I think practically reading this report as a woman especially, I found very distressing. I have never given birth, but I can only imagine what a pregnant woman would feel reading this, because it really was scary. And I think as well, for me, the experience that I have, that my friends have had in the ward isn't just about being in the ward for the time that they're in the ward. Once they had a bad experience, and sadly I do have a friend that had a very, very bad experience of care in not at Basildon, I will say, outside of the borough, and it massively impacted her in the coming weeks, months and years, I'll have to say, after. She was so frightened, and in those moments where, as I understand, I'm not. As I said, I haven't given birth, so I can only speak from experience of friends, that those initial hours and days and months after, that bonding that you get with your baby was massively impacted because of the distress of everything that she went through. So, yeah, it was a really hard report to read. My question now is, and so many good points have been raised already from my committee colleagues, is that, are all the staff in place now? Just looking at the report here, I see that there was 29 additional midwives, 2 consultants, a fetal surveillance lead midwife, and a better births lead midwife recruited. Are they all now in post?
So by the end of, or by January, of the 140 something clinical midwives that we have in the unit, we'll have 6 vacancies if there's no more change. So we will be virtually fully established. Those specialist posts have been appointed and the consultants have been appointed. So we have no consultant medical vacancies. You will appreciate, I'm sure, that midwives are a nationally hard to recruit group. But of all of the I think there were 38 student midwives who graduated from Anglia Ruskin University and Essex University. They all opted to stay with the MSE group, and all of the ones who trained at Basildon opted to stay at Basildon. So that tells you something, when there's a real market for them, that they actually wanted to stay and work in the unit. And I think that's quite a reassuring message.
Yeah, no, thank you. I appreciate that, Claire. But as I would say, you know, like my other colleagues, this needs to be sorted ASAP, and we will be looking at it again very, very soon.
Yeah, no, I mean, I have had the joy of giving birth 3 times, and I do know how important it is. I remember every single one of my deliveries. I remember the midwife, the room I was in, everything that happened. So this is personal to me, and I really do care about this. I'm giving it, you know, absolutely masses of my own personal time and that of my leadership team to try and ensure that we get this to the best place possible as quickly as we can, because you know, I am really committed and really passionate about it.
Thank you, I appreciate that.
Thank you, Councillor. Wise words. Councillor Massey.
Oh, thank you, Chair. I think the rest of the colleagues in the committee have summed up a lot of what I was going to say. Sadly, I've actually experienced some of the shortcomings that the CQC personally, for my own family, have in the past. And reading this report brought back a lot of not very happy memories. And yeah, I completely agree. We need to get onto this as soon as reasonably possible. And my question was going to be for you, Claire, about bringing in some of the leadership team. So I'm really pleased to hear you suggested that, to restore some faith in mothers-to-be in Thurrock, that Basildon Hospital is going to be the correct place for them to bring their children into the world.
Thank you, Councillor. Claire, could I just ask you a more direct question about care? If a lady comes to you on a Friday evening that is pregnant and is concerned that they may have miscarriage, how soon can they have a scan?
So at the moment, we don't have 7-day scanning for women who are not bleeding or in significant distress. So, or if we suspect that they're having an ectopic pregnancy, for example, then they would be scanned. But we don't have a routine scanning service. What we are trying to do is establish one 7-day-a-week service, at least in one location across the 3 hospital sites. So that's a priority for us to try and ensure that, although we might not be able to get it at Basildon, or it may be at Basildon, but across Broomfield, Southend and Basildon, we can offer that 7 days. Again, ultrasonographers are very, very hard to recruit, and that's one of our other limitations.
Yeah, unfortunately, 13 years ago, I was given that answer as well, and was also told by the nurse that if the baby's dead, the baby's dead, and to come back on the Monday morning.
Well,
unfortunately, the baby had passed away. But I do hear one of the letters I've got from a lady is exactly the same situation has happened. I just think if there is a need to get this 24-hour scanning facility there, and we can look at, pushing for that somehow, because I think that peace of mind for ladies coming into the hospital is really important.
Yeah, I completely agree.
Okay, I've still got 2 hands up. Councillor Maldoni, who else we've got? Elizabeth Rigby. Councillor Rigby.
Thank you, Chair. Thank you. Yes, so reading through the report, a lot of the issues do seem to be communication concerns. But looking at the training, the quite sort of low completion rates, I do appreciate we've had COVID. But given that they're mandatory, does that not affect their professional practicability? I mean, if I have mandatory training, if I don't complete it, I wouldn't be able to register for the next year. So I just wondered where that was up to and whether the training had come on more from where we've got on this data here, please.
So yes, it absolutely has. The compliance with mandatory training is significantly higher. It's up in the 90% now. We did have to, across the entire trust, we did stop all mandatory training during the COVID pandemic. That was for very good reason. We've managed to recover almost everywhere, but maternity has been a particular focus. But not only have we done that mandatory training, we've also taken 97% of our clinical staff through a full weekend of training, where we brought in external experts on, you may be familiar with the term CTG. It's a tracing that's done of the baby's heart during labour, and the interpretation of that CTG really helps to manage the delivery appropriately. So all of our staff have had 2 days training. Well, 97% of the staff have had 2 days training since June. I think it was mainly in July and August that happened. And consequently, our levels of incidence in the unit has considerably fallen. So the numbers of babies who we did have one baby who had to go to a tertiary centre for cooling recently, but we hadn't had any since July. The number of postpartum hemorrhages has also reduced, and the numbers of women having emergency caesarean sections has reduced too. So there's been a number of quality indicators that are now going in the right direction. And I think when we come back, we can share some of that data with you as well, which will, I think, give you a bit better assurance than just some of the things that I'm able to point to tonight.
Can I just ask, will those refresher weekends be repeated? Are you looking at doing sort of further 2-day training courses?
Yeah, it won't need to be 2 days in the future, but there is a refresher that's required every 6 months.
Thank you.
Thank you, Councillor. I have Councillor Vessel and Councillor Maldoni. Are you still wishing to ask questions? You haven't actually. Okay, yeah, Councillor Vessel.
Thank you, Chair. Councillor Rigby's asked one of my bits, but the piece that stood out for me was we're on page 27, which we're not assured that the service made sure staff were competent for their roles. That is quite damning, Claire, isn't it?
So, I mean, I think some of that is about the CTG training that I've just described has been put in place, and all of that mandatory training that we described.
If they're not competing in the roles they're in, you know, I mean, should they be there?
Yeah.
But I know what you're saying with the COVID and everything else that's going on. They perhaps couldn't do the rest of their training. Is that what you're saying?
They couldn't do all of the mandatory training during that period of time. And that's, you know, it's important in the maternity unit that you do keep up to date with your what they call skills drills, because emergencies happen all the time. And they need to be able to respond really quickly. So, like I say, we have caught up with that training now, and you know, hoping that we don't go into full-blown pandemic mode again. Although Basildon Hospital is filling up and very busy with COVID patients, it's not really affecting the maternity unit at the moment.
Okay, thanks, Claire.
Thank you, Councillor. Just before I bring Councillor Modoni, after Councillor Modoni, we'll be moving to make a recommendation on the report. Councillor Modoni.
Thank you, Chair. Can I say how sorry I am to hear the examples that councillors have given from their own personal experience and from residents who've contacted them. I have to say from my own experience, because I had my son at Basildon Hospital, I actually received a very good standard of care, and I was very happy with the service. But I'm obviously very distressed to hear that others didn't receive the same level of service that I did. The other part that was in this for me, which I was quite concerned about, was governance. So in respect to that, I'm really pleased to see you here tonight, Claire. That really gives the message that you're taking it seriously right from the top of the trust. So that's really good. But can you tell us, has anything else moved on? Because the report identified the issues with governance, and obviously there wasn't enough communication between the board and the senior leadership team in maternity. That was probably one area where there wasn't quite so much in the report about changes that had happened. So have there been further changes to the way that the reporting structure and the governance structure that you could reassure us with tonight? Thank you.
Yeah, so the governance structure has been revamped, but we are going to look at it again. We're part of a national maternity improvement programme now, so we have got national support from the Deputy Chief Midwife for England. I was talking to her earlier today, and she's got some ideas about how we can further improve the governance structure. But we have got completely up to date with all of the investigations, you know, because obviously there's a lot of incidents do happen in a maternity unit, and they need to be properly looked at, and the learning needs to be properly taken from them. And we had built up a bit of a backlog, particularly during COVID times as well. That's been cleared. So we've got a good position in terms of all of those incidents that are currently with the CCG for sign off. And we've got a couple of other things, like 2 of our non-executive directors are maternity champions, and so they link directly with the service. They come in and they do walkabouts, they talk to staff, they talk to patients. We've had CCG and regional colleagues coming in, visiting the department. So basically what I'm looking for is for external assurance. So it's not just me saying, yes, things are getting better. So today, Rachel Hearn, who is the lead nurse for the CCGs, came in and did spent some time in the unit talking to women, talking to staff, and has given us a report back on what she described as a good visit, a good experience. And our maternity leadership team come directly to the board every month now, or every other month when we meet in public, and talk directly to the board. Diane, who's the chief nurse, myself, and the chief medical officer also brief the chairman and the 2 maternity champions each Friday on the progress that's been made during the week. So there's lots of ways that we know that things are improving, but the most powerful thing really is when women say it, and when independent people come into the unit and say it. So we're looking to do more and more of that. and the voice of women. I know Kim's on the line. We really want to involve Health Watch to ensure that the voice of women is constantly being played back into our service, so that we can be always responding and learning from the good and of course the not so good. And I guess finally I would say that if you have collected or received feedback from people who've had recent experiences in the unit that have not been positive, then please do either you share them or encourage those stories to be shared with us, and we're always, of course, we'll look into any women's concerns, because it's important that they get closure. Even if we can't change what's happened, it's important that the woman gets closure and that the staff are able to learn.
Thank you, Claire. Before we move to the recommendation, I guess what I'd like is some sort of reassurance from you that staff there do feel they have the freedom to come to you with concerns without repercussions, without fear. I know that was highlighted in the report, and for me that was one of the concerning ones, that those worries can be, if someone's got a concern, that they won't go to you, and that it does lead to a bigger error. So if you can just reassure me that's one thing you've really cracked down and worked on for.
So we've done lots of open listening events. I was walking around the unit myself a couple of days, yesterday I think actually, hearing from staff, chatting to staff. So we do it informally, we do it formally, but we also, just to ensure that there's no barriers, we have an independent freedom to speak up guardian service that we have trust-wide, but we've asked for someone to be in the unit twice a week, all day, just listening and providing an opportunity for staff to talk without, and that's completely outside of the management hierarchy, if you like. And we'll get regular feedback from them. So
Brilliant,
2 days a week, that freedom to speak up person is in the unit, or will be in the unit from next week.
That's encouraging, thank you. Councillor Russell, I was just about to make a recommendation.
It's all right, only a quick one, Chair. Sorry, if you're going to go to the recommendation, I'm probably one of those. You've probably got lots of good staff, Claire, but we can pick this to bits all night. But I think I don't really like noted reports because I can't see the point. We can hear all evening and pick you to bits, because of what's been written. But I think we want to see something come from this, not as far away as March. I don't think we need to see some in the next few months, a change, because if that's what's happening at Basildon, and anybody's reading that, as Councillor Holloway said, it's going to worry them no matter what. And members of the public are reading this now, So I don't really like noted reports. So I just wanted that to go down, Chair. Thank you.
Thank you. Thank you, Councillor.
Yeah. I think there's something about the right time to come back and demonstrate improvement, because you probably would want the CQC to have said that it's improved as well, rather than just me. So I think the clinical team would be happy to come back, but I think March or April time is probably about right.
Okay, thank you. With that, I'll make a recommendation that is added to the work programme. Obviously, our concerns have been noted with it. Councillor Vessel was absolutely right. We could sit all night picking our concerns out of this, but if we can add it to our work programme for March, I think that's the earliest time we can fit it back in. It'll give you time to have some sort of feedback onto your improvement system as well. And let's hope that the pressure of COVID doesn't complicate any matters for you. We do appreciate you coming tonight. Honestly, we all know the pressure you're under, and none of us want to be in your shoes at the moment. We totally appreciate that. Thank you. So Jenny, if we can add that to the work programme at the end. Thank you, Claire.
Thank you.
You're
very
free
much.
to go.
Thank you.
Thanks
a lot.
coming. Thank you.
Thanks,
Bye.
Claire.
Bye.
Yep. Okay. Item 7. We have Mark Brooks from Mankind. So this presentation has come about due to concern risen by the portfolio holder that male domestic violence were not being cared for within our area, with things like no secure homes or anything like that. So I'd welcome Mark Brooks to the meeting and ask him to introduce his presentation, please.
Well, thank you, Councillor, and thank you everyone for inviting me this evening. In terms of the presentation that I've set out, which are in the papers for the meeting, I'm happy to go through the presentation slide by slide if that's available, or I can just talk about the contents in a summary. How do you wish to proceed, Councillor?
I think if we could briefly just go through them. I say I do know we have these, but I'm aware that people are viewing this online and won't have this in front of them.
Okay. Right. Okay. Did you want me to load the presentation up?
Yes, if you just share, I should be able to share on your screen.
Right. Okay. Let me do that. If you bear with me.
If not, you can just briefly go through it if you know it off by heart.
Yeah, I do indeed.
Yeah, that's fine.
Yeah, so okay, I'll just go through the presentation and said that they're in the papers. So broadly speaking, across the UK, 1 in 6 men and 1 in 4 women will be a victim of domestic abuse in their lifetime, and that equates to around 800,000 men a year and 1.6 million a year. Now, just looking at the situation in Essex, just under 6,000 men a year report to Essex Police as being victims of domestic abuse, and that comes out to around 1 in 5 of all victims who go to Essex Police. There's a number of organisations in Essex. Obviously, that covers Thurrock, and Thurrock funds those organisations, and they're very supportive of male victims. And that obviously includes Changing Pathways, which I think you do indeed fund. One of the issues, and you mentioned it, Councillor, was around the fact that there's no refuge or safe house in Essex, and also given the proximity of Thurrock to London, there isn't actually any refuge or safe house in London either for a male victim of domestic abuse, which also includes male victims who have children, but also male victims who are victims from the LGBT plus community, and also victims of forced marriage or honour-based or so-called honour-based crimes. So it's not just an issue for domestic abuse directly. And the nearest is in Northamptonshire, which is 90 miles away. And our charity and a member of the public have been talking to the Police and Crime Commissioner and local authorities, unitary authorities in Essex, about how they can go about seeking funding from the government to at least have one refuge or safe house somewhere in the county. And those conversations are with the Police and Crime Commissioner at the minute. In terms of who domestic abuse can happen to and who men tell, around half of men don't tell anybody that they actually are a victim of domestic abuse. And calls to our helpline show that men who do actually come forward to our helpline have been a victim for at least 6 years before they get help. Some men called us far earlier, but also other men have been suffering for decades of this. Around 15% of male victims actually tell the police, and only around 6% will actually tell their local council, and far fewer a specialist service that supports male or female domestic abuse victims. One of the issues that we've often said is that there's a lot more male victims out there, but only a few actually tell a local domestic abuse service. So only around 1 in 20 of clients of domestic abuse services are actually men, when of course the numbers in the domestic abuse victim population are around 20 to 25%. In terms of who it can happen to, there isn't any kind of stereotype. So whilst we get men who are unemployed calling us, we get people calling us who are GPs, we even get police officers, we also get people who are teachers, people who are in the city, as well as men who are in the trades. So in terms of there being a stereotype male victim, there just simply isn't one. In terms of the main barriers that they face 4 main barriers. The first one is around masculinity. It's not masculine, it's not in the masculine or male script in terms of behaviours of being a provider or a protector, and also being independent and strong and resilient and stoical. So for many men, that's how they're brought up to feel they're the behaviours of what it means to be a man. So if they are a domestic abuse victim, they find it really hard to understand or even recognise that they're a victim in the first place. It undermines their sense of what it means to be a man. It means that they're not strong, they're not resilient, they're not providing security for themselves or their children if they have them. And also there's a real element of shame and embarrassment and pride, and also for many men of fear of ridicule. The second barrier is around societal impact. And for male victims, the societal view broadly is that men aren't or very rarely are victims of domestic abuse. And how that then impacts on male victims is that they fear that they won't be believed, or they fear this ridicule. They fear that they'll be the ones accused of domestic abuse. And actually for many men, that they fear being stigmatised for getting help or losing contact with their children. And on the flip side, the societal response is that society, and that obviously includes some agencies, but also members of the public, friends, family, work colleagues, that they don't quite believe that a man is a victim. They do actually ridicule them in some circumstances. They're not encouraged to get help. There's not enough personal or what we call professional curiosity. Do GPs, for example, ask the same questions of somebody they suspect to be a male victim than they rightly do for a female victim? And also there's a kind of empathy gap where society believes that men generally need less help, and they're issues that society impacts on men and creates more barriers. The last 2 areas around the lack of visible services. How do you get men to understand and connect to support? Are services really signposting very clear that they're available for men? Are they well funded for male services and support? Do all the police officers in Thurrock and in Essex as a whole know where to signpost male victims? And also do services like GP surgeries? Does your housing department, is your social services department really being professionally curious and actually thinking about whether somebody in front of them that they're supporting is actually or could be a male victim of domestic abuse? And certainly look at any of the training or the policies or the information that support workers within Thurrock Council actually have who may come into contact with male victims. The last area is around public policy. It's really important to be gender inclusive and gender informed. That really supports female victims as well as male victims. And just to be clear, whilst our charity supports male victims and our focus is on them, obviously we want to see far more investment and support for female victims too. It certainly isn't a competition between different victims because of their genders. So it's really about having this gender inclusive and gender informed approach, not making any assumptions about a man whether they actually are a victim or not, making sure that your website and any public relations and campaigns that you do on domestic abuse are actually very clear that they're available and focused and targeted at male victims as well as female victims. And again, really just ask yourself and your officers and Thurrock Council as a whole, are you being as male victim friendly as you possibly could to support any male victims of domestic abuse, which will be within your borough, and there certainly will be several thousand. That's all I've had to say, and happy to take any questions.
Councillor Ralph, you're on mute.
Some will say that's probably the best way to be. Okay, That was absolutely brilliant. Just going to open up to Councillor Edson first of all.
Thank you, Chair. Mark, did you say that there aren't... Sorry, I seem to have an echo on. Somebody got another mic on. I'll take... Does that help?
Yeah.
No? Yeah. Sorry, Mark. Did you say that there is no places in Thurrock for men?
Sorry, I think we've got a mic on in the council chamber.
Yeah, you must have, because you're getting an echo.
I don't know how we can turn the mic off in the council chamber. Jenny?
No, that's the webcasting one.
Oh, is
that
it?
has to be on. That's all. It's been on all night, Councillor.
All right. We just got really bad feedback. Okay, if we try again.
I'll go again. No echo now. All right. Mark, did you say there aren't any places for... Can you hear me, Mark?
Yeah, I can, yeah.
Okay, that's all right. Did you say, because we have got refuges for women, haven't we, in Thurrock? I mean, I know one not very far away from the A13, but are you saying we've got none for men at all in Thurrock, or nowhere to send them in, even in the Essex area?
That's correct. There's no male refuge or safe house in Thurrock. There's none in Essex. There's none in London. And also, there's none in even neighbouring counties. I mean, I'm speaking from Kent. There's none in Kent. There's none in Suffolk. So the nearest is Northamptonshire. It's really strange in terms of the geographical spread across the UK, in that there's about 38 organisations that have refuges for male victims, and often they have. And they will have refuges and safe houses for female victims as well. They're run by the same commission services. But there seems to be a real split in terms of most of them are either in the North, the Midlands, South West or Wales. So the home counties and London, that there isn't any, and it is a real issue. So if there is a male victim and presents as needing a refuge or safe house to Thurrock Council, the nearest place that he can go to is in Northamptonshire, and that's only if they actually have vacancies. Now, often it's not always safe to actually have a refuge in an area where potentially the perpetrator is. So often you might have a male victim who may in Thurrock, but you may put him in a safe house or refuge in Chelmsford or Southend or even in London, and that's how it tends to work. But the issue is that there just isn't any in the direct vicinity or surrounding vicinity at all, and it's an issue we've been talking to the Police and Crime Commissioner and unitary authorities to try and get resolved.
Thank you, Mark. I think it's something. I mean, I sit on the police and crime panel, so it's something we can also bring up with the commissioner. So it's good to know that. I mean, I didn't know that for one, so it's a good point. I will bring it up.
Thank you, Councillor. It's sad to hear that. I know there was once one in East London that we could use. So it's sad to hear that that's no longer available. Councillor Massey.
Thank you, Chair, and thank you, Mark, for your presentation. It sounds like Mankind are doing some really good work, and thank you very much for what you're doing there. I too, like Councillor Redsell, was really surprised that we haven't got a safe house in Thurrock and the rest of Essex. And Councillor Redsell mentioned the Police and Crime Commissioner. Could you confirm up that how is he making that decision at the moment? What's the process he's going through?
Well, we myself, and there was a survivor actually in Castle Point, which I know is obviously not in Thurrock, but he had contacted me to say that this was an issue and he wanted me to take it up, or the charity. So I worked with him and we contacted Police and Crime Commissioner and the cabinet members for the unitary authorities. So we have spoken to the cabinet member responsible in Thurrock, and what we asked them to do was to get their heads together to actually work out how they could create a refuge or safe house, or a couple approach often the government for funding, because there is always a lot of funding from the Ministry of Local Government, Housing and Communities, and that they tend to help fund local authorities for female refugees, and therefore it was a matter of the I think there's 4 unitary authorities and the Police and Crime Commissioner to get their heads together. It's not actually a Police and Crime Commissioner responsibility. It is actually a local authority responsibility to house vulnerable adults. So Police and Crime Commissioners often get involved because they feel that they ought to, but it is actually council responsibility. And under the Domestic Abuse Bill, when it becomes an act, if it goes through Parliament, there is a new statutory duty on all local authorities, tier 1 authorities, which I think Thurrock will be, to ensure that all domestic abuse victims who need emergency housing, which includes refuge and safe houses, will have to give them. And that obviously includes, because of equality and inclusion, male victims as well. So I would certainly urge Thurrock Council to work with the other councils to actually move this forward, because on the 1st of April, if a male victim is vulnerable, even more so with a child, cannot get that housing, then you'll be in breach of that act.
Thank you, Mike. Thank you, Councillor. Councillor Massey, do you want to come back in?
Just briefly, thank you very much for that, Mark. That's a really good detailed answer. And I think if there is a general consensus around the committee that perhaps the first safe house in Essex should be in Thurrock, because we do have excellent transport links all around Essex. Perhaps you, Chair, could use your influences to write to Police and Crime Commissioner, and also to speak to the relevant officers in Thurrock Council to see if we can make that happen. Thank you.
Mark?
Yeah, thank you, Councillor. If I could just add, just in terms of misconceptions as well, the organisations that run refuges for female victims in Essex, including Thurrock, are exactly the same organisations who would be funding a refuge or safe house in Thurrock. So, there's no need to look for new organisations or any other funding models or anything else. It's exactly the same process, organisations that currently do it for female victims. So there's nothing scary about this.
Thank you, Mark. I want to throw it over to Roger to see if any advice Roger could put our way.
Well, obviously, this is something that's followed through the Community Safety Partnership and has been discussed previously. So I think this is something that we most probably do need to look on a larger footprint than just Thurrock. So I will certainly discuss it with Julie Rogers, my colleague who leads on this area, to see how far those discussions have got. I'm not on top of the detail on this one, but I'm more than happy to take it away and discuss it with Julie and come back and let members know.
Thank you, Roger. Anyone else with any more comments? No. Thank you, Mark. That's very interesting. I say it's highlighted the problems that some of us may not have known are out there. Especially, you've educated some members tonight with the fact that there is no safe house for male victims in Essex. So I was under the assumption there was still one in East London. It's sad to hear that that's no longer available. I know that we do have a policy of people that are at risk. We can move anyway, but it's hearing that we have no safe house. It also brings up concerns with our safeguarding policy. I will take that on board that we do need to ensure that all our literature is inclusive and to include male victims as well. So I hope you feel it's worth your time. I will feed back to you I will be moving forward this with the Cabinet member, and hopefully bring back to HOSC a later date to bring it back up and update you, especially regarding if we have any movement on maybe helping with a safe house within Thurrock or with Essex as a joint partnership or something like that. Again, thank you very much. Thank you, Mark. You're free to go. Thank you. Okay, item 8. This is a mental health update. The report can be found on pages 65 and 92. I welcome Neil Leonard and Sue Waterhouse and Limbrick Gall from EPUT for the meeting to ask them to presentation first.
Okay, thank you very much, Chair. As I say, my name is Nigel Leonard. Colleagues from EPUT, Sue Waterhouse and Limbrick, as you quite rightly have said, are in the audience. So Sue is our Director of Mental Health and Limbrick is our Associate Director. So we have a range of expertise to answer any questions that members have. I'd also like to say that I welcome the approach that Thurrock has taken in looking at mental health services as a whole, because they are very integrated in nature, and hopefully that will be shown by the presentations that will be presented to you this evening from our colleagues as well. I want to just start with our response as EPUT to the COVID-19. This is very relevant because the level of investment, which is very exciting, that's due to take place across Thurrock and across Mid and South Essex in particular, is to be welcomed, and it was also available to help our response to the COVID crisis. So just very quickly, similar to the local authority, the unitary authority and our CCG colleagues, EPUT has maintained a very strong emergency planning response, and we have, similar to the local authority and CCG, redeployed staff accordingly. And certainly we've had clinicians from other organisations, especially CCGs, helping us through the wave 1 of COVID. What is pleasing to note is we have never stood down any mental health service throughout the COVID process, and that will be the case as we approach the potential pressures of the winter to come. We, within the region as EPUT, have switched significantly, as a number of statutory and voluntary organisations have, to the use of technology. Our clinicians are amongst one of the highest users in the region of technology to provide online support. And where appropriate, we will provide telephone consultation and support to our clients as required. We are very conscious, as I'm sure colleagues on the committee will be keen for us to clarify, is that we have risk assessed all of the people that use our services. Those that have been unable to utilise technology, we have a loan service in place that our clinicians take advantage of. And you will hear later, probably in the question and answer session from Limbrick particularly, of the work we've done to make sure that we've got regular contact, particularly with the most vulnerable in our society. I'm sure that you may hear from our colleagues from the CCG that there was a paper that was brought, that members will recall, in September last year around our crises and 111 services. This really just shows the integration that you have between secondary care services, the CCG, local authority and our voluntary partners around delivering support for everybody, anybody who has a crisis on a 24/7 basis. The report last September said that the intention was to have that service up and running for the 1st of April. Delighted that in joint working with all of our partners, that service was in place for April, and that meant that service and crisis support was available throughout the COVID period. We've also, at very short notice, set up a number of initiatives during the COVID period, including A&E diversion, to actually alleviate the pressure on A&E services so that we could actually provide that support and the support quickly to those people that needed support and would have presented to A&E. Finally, I'd just like to add that because we are a specialist mental health provider, our psychological services particularly have been available to all healthcare workers who themselves potentially may have experienced some trauma through the COVID response. So we've been very active across Mid and South Essex in providing that support to our colleagues as and when appropriate. Certainly, this is a very exciting time, as you will have seen from previous reports by Roger and Mark and colleagues for mental health services, in terms of the level of investment that will happen over the next couple of years for both secondary and primary care. Certainly from our perspective, this has to be, and we're delighted to say is being delivered through very strong relationships we've developed with colleagues in Thurrock in particular, and the close working that we have not only with our statutory partners, but also with our voluntary colleagues as well. We think that this has led to faster responses and improved decision making, and certainly within the services that we have in place, as you can see from the report that we've mentioned, that we are actually in a position, because of the good work in Thurrock, to share that best practice to other parts of Essex. And that's something that we're delighted to see. Thank you very much.
Thank you, Neil. Thank you for that report. I'll throw it over to Councillor Madoni.
Thank you, Chair. Thank you, Neil, for that report. Can I just clarify something first? Is this report the result of the mental health deep dive, or it's a report on the mental health COVID response?
Yeah, what we try to do within the report is to talk about our response to COVID, but also recognising that there is a significant amount of investment taking place with mental health services, and it looks at our transformation and future investment process for the range of mental health services that we're looking to provide, not only in Thurrock, but also across Mid and South Essex.
Thank you. I think somebody else might need to answer my question, maybe Roger.
So this report was requested, if you remember, we had the update, or I think some people called it a deep dive, but it was an update in July on our mental health transformation programme. So Maria Payne, Jane Ittengata and Catherine Wilson came and presented, and there was a request that we hear directly from providers at this meeting. So what you've got is 3 of the providers, ePut, Mind and Inclusion, just doing an update on their services. So this follows out of the transformation programme update that you got at your July meeting.
Okay, so that was scheduled anyway. It's not a response to that other thing. Okay, yeah. One thing, I've got a few questions actually. So thank you very much for the reports and the updates. I read them all with interest, and I can see there's a lot of very interesting, very necessary initiatives going forward on mental health. I think what was missing from this update for me was the kind of idea. I know that we've heard about how Petersburg and Cambridgeshire has got like platinum level mental health services, and in terms of Thurrock, we haven't had that level of service. So I'm trying to get some kind of gauge of how our services have improved or how we're doing in comparison with other areas. Are there any areas that we need to still be looking at? That's kind of what I was expecting from this report, but maybe from what Roger said, that's not something that particularly was going to be provided from this report.
Councillor, if I could just say that we have set up a mental health steering group that is due to meet, I think, next week. So a lot of this is going to be covered within that group. You're very correct that no, we want to see this. It's quite funny you bring up about Cambridge and Peterborough and how they got their gold award in mental health, and maybe we would have got there if our funding hadn't been taken. But maybe another matter. I will say, Nigel, is what I'm really pleased to see is that how well you adapted to the COVID crisis, and I think congratulations to everybody on board of the team that all of a sudden quickly grabbed online services and pushed it out. Being flexible during this time has been a real credit to everybody in the services. Just going out to Councillor Redsell.
Thank you, Chair. Thank you, Nigel, for that. I think it was good what you said about you're doing telephone canvassing. I think there's a lot of things going under the radar that councillors are doing, are calling their elderly constituents because it's just that, you know, whether it goes on to be a mental problem, but I think in the COVID we're in at the moment, I think it's just going back to loneliness. You know, if you've got someone on their own who doesn't see anybody all day, a phone call is brilliant, you know, just to talk to someone, you know, about the normal aspects of the day and whatever. So I think there's things happening under the radar that we don't always see, you know, and it was good to hear you say that it's not always about technology, you know, because a lot of my residents haven't got technology, you know, they rely on that phone call to come from someone. So I think a lot of us councillors have given our numbers out. So if someone wants to call us, they can, you know, it's given out. So it's good to see, as Shane said, the work you're doing is really good, because I think we're going to see, we had loneliness before the COVID, you know, and that was around then. So I think this is going to make a lot more people, you know, and it's not always perhaps loneliness, it's anxiety of what's going to happen, you know, and that produces something else in people. So it's good to see you're doing something with calling people. You know, I just don't want it to be all about technology and an iPad and everything else, you know. There's a lot of people out there just haven't got it. So it's good to see that bit of work doing. Just thank you very much.
Okay, I'm going to pause it. I'm just going to bring in, move on to the next one. I wonder if Jane can present her report from the CCG.
Thank you, Chair. If it's all right, I'm going to share the presentation so that everybody can see what it is we're trying to do.
Yeah.
Just to follow on from what Nigel just updated on that report, Thurrock, actually, we've been trailblazing in the system, and a lot of the services or models that we're developing in Thurrock are now the ones that are going to be used more or less by the rest of the system. And as Nigel also said, there's a lot of investment coming down over the next 2 to 3 years to support the development of especially community mental health services. Yes, we have just recently launched our crisis service. So that's kind of like the downstream services are now, I can say, quite significantly well-resourced. But then we know very well that we do have some kind of like gaps upstream. And one of the things that we have done quite significantly is looked at how we start navigating or managing some of those gaps that we have identified, especially, you know, with the people whose needs don't fit very nicely either in primary care or secondary care. And when we've looked at our data, that's about almost 80% of the people who are kind of like doing the rounds in the system because their needs are not being met that well in either part of the system. So what we've come together as partners, both commissioners, clinicians, service users, voluntary sector, local authority, to look at transformation more widely than just kind of like around services. And this is a model we have come up with, which we will be implementing as wraparound services for our respective 4 areas, our 4 PCN areas, to ensure that primary care is well supported. And there's going to be quite a significant level of, apart from investment, but specialists, different specialists, both clinical specialists and people who are not clinicians, but also working within the community to ensure that we have that seamlessness of offer to meet needs irrespective of where they will be presenting. And apart from it happening within the primary and community care side of things, we also want to look at those people who are stepping down from inpatient services, those people who are coming in from urgent and emergency care. So there's that seamlessness and supporting those with very, very complex needs, especially those with even dual diagnoses as well. And looking at our personality disorders pathway, because that's one of the areas we have identified. Actually, a lot of our patients have personality disorders. And we know we do have a small gap around psychology, which we are now going to resource a little bit more to ensure that we have that seamlessness and the needs are being met either from primary care, or if they're required to go into secondary care, that happens as well. So that is going to be what our clinical model will look like. But I just wanted to show you how the services are eventually going to knit around together, so that when someone presents, whether they're presenting in primary care or secondary care, people are not being assessed multiple times. People are being supported at the earliest possible time. People are being supported according to need. And we provide that kind of we wrap care around people as much as possible, and prevent where possible people's needs having to escalate. And this is also aligned with some of the work that Catherine and colleagues are doing also in social care to support, not just from a clinical perspective, but also the social care element, to wrap around a very kind of comprehensive care, kind of around our respective PCNs. So as I said, we are investing quite significantly, and we're going to bring in a lot of more professionals to support our GPs in primary care. We are looking at supporting more people in primary care and reducing a lot of the people who are, for example, in outpatient caseloads in secondary care, to release capacity for our consultants also to support our GPs within primary care. So as we're meeting people's needs a lot earlier, without people having to go into secondary care, and this will reduce the waiting lists. In fact, we want to actually get rid of waiting lists if we can. Of course, this will take some time before it's completely implemented, and it will take us up to 23, 24, but incrementally we'll be able to start seeing that difference, and we'll be able to keep the committee apprised on the implementation. So I don't know if there are any questions.
Oh. So I couldn't get my mute button off. Thank you, Jane, for that. One of the questions I'd like to ask, but I'll come back to it later. I just want to hear the summing up. Catherine, could you sum up for me, please? Catherine Wilson.
Certainly. Are we expecting a presentation from Inclusion first, Chair, or because I was going to do the little bit about Mind, but I can do that first. That's fine.
I haven't actually got that on the agenda. Have we got that on there, Roger?
It is, Chair. You've got two additional presentations that are attached to the report.
Right.
Appendix 1, Appendix 2. So from Mind and Inclusion, would it be best if we just have all the presentations out first,
yeah,
and then have all the questions at the end?
Who would be? We've got Catherine on the agenda next. So the Jane, and then it says Catherine. I don't know who would be doing the one.
If Catherine can do the Mind one, and then we might. I don't know if there's anyone from Inclusion here. We might just have to then ask. Robert's here. Fine. So Catherine for Mind and Robert for Inclusion.
Okay.
And questions, Chair.
Thank you. So yes, Lynn Morgan, the Chief Executive of Mind, asked me if I would just represent her today and just briefly go through the services that are offered by Mind and how they have been delivered through the pandemic and going forward. So on the report, there are a list of services, and some of those will be covered when Robert gives his presentation. But there are a number of services that are directly commissioned from adult social care, and that's day opportunities, advocacy, counselling and group work, and the carers service. And some of the challenges that Mind have faced, of course, as Nigel said in his presentation, the change from that face-to-face group work with people to the kind of online and telephone solutions. So certainly, Lynn wanted just to point out that, her staff have been amazing and have really adapted well to offering different solutions for people. And they've had quite a lot of referrals through the pandemic, as I'm sure everyone would realise. They have looked at Zoom meetings, telephone sessions, WhatsApp groups for people, and virtual programmes of support such as armchair yoga, art sessions, and later on in kind of through the summer, some socially distanced meetings as well for people. They were able to really focus on the IT solutions. They were successful in some bids for funding and also had some support from the CCG and the council so that they could have more IT solutions to offer to individuals, so that courses and counselling could continue. So the day opportunities, as I said, really were around wellbeing sessions, such as the art sessions, etc. Advocacy is not a solely mental health service. It's a contract that's delivered by Mind across all specialisms, but obviously people who have mental health challenges do access that as well. And they were able through the pandemic to offer face-to-face support where that was required with appropriate PPE in order to support people through some very tricky and difficult situations. Counselling was a challenge. A lot of people wanted that face-to-face support, but they worked really hard, particularly with people who were on the waiting list for counselling, and ringing people and doing those extra calls that have been mentioned before, you know, just to ensure that people felt connected and supported. And they were able then to work with people and bring them into a counselling solution. And the carer services, again, are not solely mental health, but they did have a lot of contact from people who were supporting those who have mental health challenges. And much of that was around practical support, such as shopping, advice, needing equipment, and also carers assessments. And they were able to deliver all of those with technology solutions. And finally, Lynn just wanted me to say that they are predicting a continued growth in demand, and they're planning for a 20 to 25% growth in referral rates to Mind. And one of the key challenges they think they are going to face as we move forward through the winter is being able to recruit more volunteers, and particularly now that we have moved into lockdown again, and the worries around whether that will be extended or what will be happening at the end of that lockdown period is of great concern in finding the volunteers, because a lot of the services that are delivered through Mind are delivered by volunteers. That's it. Thank you.
Thank you, Catherine. Okay, so we now have Robert to present the. Thank you.
I'll share some slides if that's okay.
Yep.
Right, this is an overview of the service, what we provide within Thurrock, and what's going on. So first, the primary service is the. Can you see the slides okay?
Yeah.
Yes.
Yep.
Yes.
The IAP service, where we're providing steps 2 and 3 interventions for individuals with common mental health disorders, primarily depression and anxiety. We also, in partnership with Thurrock Mind, provide the Recovery College, which provides informal education to assist the well-being and recovery of individuals who have mental health conditions. The IPS, the Individual Placement Support, which provides employment aid for individuals in secondary care. And again, working in partnership with EIP, the Early Intervention Psychosis service, caring for individuals and their families experiencing their first episode of psychosis. And moving forward in the near future, we'll be providing support for ARMS, the at risk of mental states, for those to be deemed at risk of developing psychosis. And that's something that will be launched in the near future. Also to be implemented shortly is a step 4 service, something that Jane referred to earlier, to provide support for individuals with more complex needs. And we also provide the Vision's substance misuse service within Thurrock. And I think if there's one thing that pulls all of those things together, it's effective partnership working. It's central to the way that we do everything, be it linking in with Visions, the CCG, our primary care networks, our colleagues in APA. Working together is central to the way that we work. So in terms of our response to COVID, we were able to move very quickly from face delivery to telephone initially and video consultation. This was aided by all of the therapist teams already having laptops and equipment, so they could move from delivering in the central hub and GP practices to working from home. We risk assessed, set up them with the additional equipment. Many made a trip, picked up additional screens, etc., so they could work from home in a safe way. We found that referrals dropped significantly countrywide, but they're slowly building now again. 2 days last week, we were back up to activity, targeted activity levels. And that big gap in referrals, the drop, has allowed us to clear any waiting lists that were there. And we're expecting a surge. And as was suggested for Mind, a 20 to 25% surge is expected over and above contracted levels. So we're working to try and deal with that 20% more. We also spent significant time supporting the therapists to optimize remote delivery outputs. Suddenly staff found that instead of sitting in front of somebody and being able to pick up all the nuances of their body language and how they spoke, that a massive part of their engagement was lost when it was moved over onto the telephone. So they had to work a lot harder, strain a lot further to maintain that deep level of connection. So we provided lots of support to staff to understand that, to build in separation routines at the end of the day between their working day, what would naturally occur when they were packing up the laptop and going home and arrive home, suddenly from switching the laptop, and how do you end the working day? So we spend a lot of time supporting staff that way. And thankfully, it appears to have worked. Not only have recovery rates increased, we're running just over 50%, the national target, they're now running at nearly 60%. But also in terms of engagement, it's increased from about 75% to over 80% since the 1st of April. So service users find it easier to log onto the telephone. Some still prefer to do it via the telephone. Many are happy with the video consultation, and they're attending to a greater degree. The waiting lists have reduced. For every one patient in treatment, we've got 0.67 of a patient waiting. So that's good. And we're back on delivering online groups and computerized CBT via the Silver Cloud platform. Key workers are being fast-tracked into treatment. Waiting lists are short. They're not really a waiting list. They're a staging service. But key workers, NHS or any other care worker, are being fast-tracked straight into treatment. All treatments, including those for trauma, are being delivered again. And the plan is to continue remote working with reviews until we can identify when face-to-face work might be feasible. If we return to face-to-face work at the moment, there will be a significant impact on productivity because of having to clean the room after each client, not being able to have more than one client in the waiting room, etc. So we're continually monitoring what we can do and what is the best way to work. And achieving higher recovery rates means at the moment we're going to carry on there, the way we're working. There have been a small number of patients, about 60 since the start of lockdown, that have said, I can't do it this way. A significant proportion of those were actually because they had children at home or they had a partner at home and they didn't have a secure place where they could talk interrupted, or they couldn't leave to go somewhere else because they now had no one to look after the children. So that for those individuals, we've said we'll invite you back as soon as we start face-to-face again. Or if you find another way that you can engage with us or want to engage on the telephone, contact us and we'll take you straight into treatment. In terms of normal access into treatment, we risk assess and do the initial treatment normally within 14 days of receipt of the referral. And second appointments are averaging 37 days wait at the moment. We work closely with our secondary care colleagues, and our senior clinicians attend the weekly MDT meetings to talk about cases we want to step up or they want to step down. So there's a real collaborative, effective working relationship with our secondary care colleagues. Lots of numbers on there. I'm not going to go through to them. I'll just pick up a few. Each year on year, the service has grown. In terms of access to therapy, we missed the target in March. We were on target to meet year 4 access rates until the last week in March when COVID struck. Access to, we've got an echo on somewhere, I'm afraid. Access to treatment, the national target is 75% in 6 weeks. We've consistently smashed that target. 95% should access treatment within 18 weeks. Again, we've consistently smashed that target. The national recovery rate is 50%. And we've met that target consistently, other than the first year when we first took over the service and weren't able in the first few months.
Hi, Robert.
Yep.
We're just running short on the time now.
Right. Okay.
We have got the slides in our pack. I just wonder if we could sort of come to like the summary, if that was okay.
Yeah, not a problem. Do you want to run through the challenges, or
actually, yes? Could you run through the challenges just quickly for us?
Yeah, the service is growing. So one of the challenges that we've got is a high number of trainees. So we need to support those trainees to ensure effective clinical practice. So we're doing that by case management and clinical supervision, liaison with the universities, and creating a buddy system for all of the trainees. So not only have they got a clinical supervisor, line manager, they've got another experienced colleague that they can link in with. And we also need to maintain the morale and fighting fatigue, as we see this is going to be a long winter. So again, lots of support, interaction with the staff, weekly meetings, and trying to introduce some humor, some interaction that they would normally get in the kitchen when they're making cups of tea, talking with each other. So spend a lot of time on there. Coping with the surge, we want to make sure that we deal with these extra referrals and it doesn't result in a waiting list. So we've secured some central funding to get some more trainees in January to deal with that surge. And there's been an increase in the complexity of patients accessing the service. So the people who are really in need, they've carried on coming. But the ones with the lesser need, they're the referrals that we haven't seen. So we've got a process where we're about to go out through the primary care networks to encourage people that are anxious about COVID to contact us, to get people accessing the service earlier so we can help them before the conditions deteriorate.
Brilliant. Thank you, Mark. We appreciate it very much. We want to move on to the questions quickly. If we could unshare your screen quickly.
Yeah.
I don't know if we've got back to our normal screen. I know we may be stuck with, but has everyone got the normal screen? We've still got Mark's presentation. Oh, here we go.
Yeah.
Thank you. Welcome back. Right, I just want to go straight over to the questions. So if I bring in Councillor Modani first.
Thank you, Chair, and thank you to everybody who presented tonight. Obviously, some great, really, really positive reports there, and obviously we're immensely grateful for all the hard work that everybody in our mental health services and our voluntary services have been doing to support our residents, particularly during lockdown. And it was interesting to hear from some of the reports that there have actually been some positives to going digital. And I particularly like the peer-to-peer support in the Mind report about how people were reluctant at first to use video conferencing and how you actually utilised knowledge within the group to encourage other people to come and join and improved your rates. I thought that was really excellent. But I do want to speak a little bit about, I know we've been asked only to note this report, but you know, it's a scrutiny committee, so that's we're not really here just to note reports. So I did want to speak a little bit about digital inclusion and digital exclusion, particularly because it's being highlighted at the moment because of the lockdown conditions and as we go back into a second lockdown. So I'm wondring, well, actually I'll say a little bit about it first. I mean, we do know that it is an issue. There was an ONS report in 2019 which showed that about 10% of the adult population actually suffer from digital exclusion. So I was wondering, what mind are people paying and what steps are you taking to reach people who can't access your services because they either can't afford the actual equipment to do it, or they haven't got the digital skills to do that. Obviously, we've had one example from Mind of something they did. And how can you improve access to services as we go into this second lockdown, as we're going to have to, you know, do more things from a digital point of view again? Thank you.
Can I come in there from an EPUT perspective? Just to sort of reiterate what Nigel said about the Carephone loan technology system that we have, but also to really highlight that certainly in secondary care we're not just doing digital appointments or telephone appointments. We were encouraging that in the first lockdown. What we quickly found was that there are a number of people who don't cope well with that and actually need a face-to-face. And once PPE stocks were abundant, we've actually instructed that clinicians need to look at when a patient was seen last face to face, and actually if that's been more than a month, that they'd absolutely need to encourage a face to face appointment, either in the home or at our services. What we've avoided doing is having a kind of blanket rule, because we really need to talk to each patient individually to see what works best for them. Some people are really scared of NHS, healthcare staff going anywhere near them at the moment, and we risk assess all our patients in terms of their vulnerability. We've had a lot of questions this week around, oh, does that mean we stop seeing people face to face now? And the answer that we've been giving is no, you don't. We carry on. Yeah.
Thank you very much. Can I just come back on that? I mean, I think from the reports it was very clear that you've done really well at helping staff and the users of your various services to make that digital leap, and where that hasn't happened, it's really reassuring to hear that you've been carrying on with face-to-face appointments. So that's great. But I'm just wondering about how people can access some of these services. Like, for example, I was very interested to see that hoarding was a part of a service that we can now refer to. Oh no, sorry, that's in the safeguarding report. But how, just this idea that referrals dropped off. I mean, was the reason for that referrals come from clinicians in the main, and that's why referrals dropped off? I just wondered, were there issues with accessibility to services that we can learn lessons from to put into this second lockdown?
So I monitor the referrals each week, and have done since the beginning of COVID in our services, and they did drop off significantly in the beginning, down to about 50% of previous levels. That may well have been because our main gatekeeper to services currently is GPs, and they are working very differently as well. But for various services, we've put out we've worked across the system to offer welfare calls to people as well. And I think what I'm seeing now is that referrals are back up to pre-COVID levels at the moment. And one of the proposals we've put in for winter pressures as well is to work with the third sector to get some additional support, to give people who aren't having face-to-face contacts, to maybe give them additional kind of phone call welfare support.
That's great, thank you. Can I just sort of make one comment on Mind and the need for volunteers? I just wondered if there would be any way to link up the services that we had locally with the Thurrock Coronavirus Community Action Group, where we had an awful lot of volunteers sign up for that with CVS. If it becomes the case that Mind need more volunteers to run their services. Thank you.
Yeah, thank you, Councillor. I just want to comment on one section that you actually brought up yourself, Councillor. I do think the initial drop of referrals could also be due to people that suffer from mental health, more like anxieties and things like that. Coming into a lockdown situation was actually very secure for them, and they actually felt very sort of almost like comfortable that all of a sudden they've been put into a protective bubble. So I think that they didn't feel they needed to access the services there, but then obviously the concern was that, say that I think they were normally doing 24 assessments a day, dropped down to about 7. So it was quite a dramatic drop off. I'm just wondering, for all the groups together, what do you think you got the most correct, and where do you think that you could have done better during this period? And that's a tricky question.
Can I come in? Go on, you, Robert, you go.
Right. I think for us, one of the things we could have done better was the IT. The transition onto Microsoft Teams coincided with the trust having problems on their network, and it took some time to configure Teams correctly so we could deliver groups, and that delay could have been done better. And obviously we've got the facility, we're delivering groups now, so that is overcome and it won't be a problem here. But to pick up on something that was mentioned earlier, I think it's right. We do get an awful lot of referrals via GPs. Individuals go and see the GP, they're depressed, they're anxious. The GP either refers them or gives them a card and tells them to come to us. And of course, people weren't going to their GP. So referrals fell. Nationally, in April, they fell about 75%. So there was a massive drop. But also, there's a thing called Maslow's hierarchy of needs. And basically, the hierarchy is you need your lower level needs met before you can consider the needs at the next level. And it was as though everybody had been squashed down into those lower levels, that base level. So their anxiety wasn't their primary concern. It was, were they going to survive?
Yeah, thank you, Robert. Lynn Brett, was that what you were sort of going to cover? Or?
It's Sue Waterhouse. I wanted to just pop in.
Sorry.
So where most of the services are saying that their access is through GPs, that's not the case in all of our mental health services. So, for example, we would see people attending A&E or our liaison or our crisis services, and we saw a drop across all of those services during the initial stages of the pandemic. And I think that from some of our other IAP services across the patch, is that people that were booked in and that we were well engaged with just stepped away. There was a real desire to shut down, I think, for whatever reason, and you allude to maybe people felt safer, maybe that's part of the case. So we saw a general drop across all of our services, and since then we've seen an increase. We're back to the 2019, and in some areas we're above that now, and I don't think we'll drop again. In terms of what we I think we did well, I think we did technology very well. We what would normally take 18 months of training was picked up in days with all our clinicians and our staff. I think we stepped up services very quickly by dropping bureaucracy, and I think that was down to us working as a system, where we worked with local authority, we worked with our CCG partners, and a lot of the barriers to working collaboratively just fell away as people just, almost like call to action. And I think that was done really well. I think that it would be nicer to have been able to coordinate our services better and working with the third sector. But I think that, it was just hands on deck, and people weren't necessarily looking beyond too much beyond the ends of what they were dealing with on that day. So those are the bits that I would say that we would need to focus better on.
Yeah, thank you, Sue. It's it is interesting to sometimes be able to take that step back and reflect on what you've achieved. And you have all as a group achieved immense throughout this lockdown. A drop of a hat. No one predicted it, and to change the service around it has been a great credit to all of you. I say this is a very much COVID focused sort of report that we're doing. Councillor Holloway, I believe, was next.
Again, Chair, sorry, it was Councillor Redsill. It wasn't me first. Councillor had her hand up first.
Sorry, Sam. Councillor Redsill.
Thank you, Vicky. It's sorry, I don't mind waiting at all. I'm very patient. I think getting back to what you just said is we've all learned in this pandemic. We've all learned to do things we never did before, and I think I don't know who can answer this, but do you think there is a core of people we still haven't got to, or are still not getting in touch with us for some reason?
Shall I take that. So I'm not sure. There is bound to be a core group of people that we haven't reached out to yet. But I think that we need to understand, in addition to that, the way that a pandemic is likely to take hold. And there are different stages to it. So some people won't have developed the impact of the pandemic on them yet. So, and we are likely to see that. I mean, all forecasts say that we can see up to a 60% surge in demand for mental health services, and that is likely to go on for between 3 and 5 years. So not everybody would have developed the, you know, whatever the impact is, whether it's PTSD, you know, that will develop in time, won't have developed right now, some of the impact of the lockdowns on people. But then we also understand that the impact of things like the socio-economic impact on people through not working, etc. And we're likely to see that at different stages as that has greater, you know, as the impact of that builds on people. So I think it's quite a complex picture that we've been looking at and trying to study, where we're likely to see it by learning from previous pandemics. And I think it's quite shocking. So, for example, one of the things that I didn't expect is that first episode psychosis develops post-pandemic. And so, and we've begun to see some of those cases come through our services. But I think that we're going to be seeing that for some time to come. You know, whereas you might think depression and anxiety would be a feature, but actually there are some slightly different presentations.
Yeah, that's what I was going to say. Are we actually putting sometimes a mental health stamp on it when it might be just anxiety? You know, people are just getting anxious and just worried about the, you know, are we going to go into lockdown on a certain date, and then the anxiety steps in, and that may be that we can do something about that. If it goes into a mental state, then we're going even further. So I would like to think that we'd pick it up at that anxiety state before it got too, you know, too bad for people.
Absolutely, because I just wanted to add to what Sue said, actually, if that's all right, around sort of the new models of care and transformation. And I think one of the things that we're really hoping is that the new models of care that are developing will be much more of an early intervention and preventative, and around building resilience in people, and not such a heavy reliance always on services. So I think that, you know, the work that we're doing with primary care, and the work that the local authority are doing with their community-led support teams, etc. Hopefully we won't be seeing so many people needing to come into secondary.
Thanks, Lynn. I just think there might be a little bit there where we can even buddy people up, you know, and get people perhaps talking to each other who perhaps live in the same street or something like that. Just a buddy on the phone to say, oh, I can pick that up and just speak to someone. That's another good thing. Sorry, Victoria, I didn't want to hog it. That's
okay. I just want to quickly cut in and just say that obviously I'm very aware of the time on this, and we've still got Roger's report to come through.
Look.
Oh, Roger, you're on mute.
No, I just wanted to reassure Councillor Redsall that although they're not designated specifically as mental health services, a number of the council's outreach services, whether it's looked after, whether it's the local area coordinators, whether it's our housing outreach team, whether it's the rough sleepers service, those have all been operating during COVID and have been visiting people, obviously, you know, with following government guidelines, Public Health England guidelines, etc. But they have been, I wouldn't say it was entirely their caseload is mental health, because clearly that wouldn't be right, but a very significant number of people have got mental health issues. So the LACs have been working throughout and have been seeing people face to face. So that sort of, if you like, those close community connections, those close community services based at a local level have very much been working throughout COVID.
Yeah, thanks, Roger. Cheers.
Thanks, Roger. Councillor Holloway.
Thank you. So my mute button wouldn't unmute. Maybe that's a sign. Also, yeah, I do have a few questions because this is such an important item, not just during COVID, but it always has been so important because the number of people that are likely to have a mental health problem is so high. It's one of the most important issues in society that we have. So my questions are, I'll ask them all at once because of time, Chair. So get your pens at the ready. The first one is to Robert with regards to trauma. It says all treatments, including those for trauma, are being delivered. Can you just tell me how many of your team currently are qualified at that kind of trauma level, and what qualifications exactly do they have? The second question is to, I guess, all services. When someone contacts your service, but you think that you're not the best people to help that person, how do referrals happen seamlessly without people repeating sometimes very upsetting stories? They build up the courage to say it once, they don't want to keep saying it. So when there's a referral, how does that work? The 37-day wait that Robert mentioned as well, that is still so high. Having a very close friend who did not in the borough, I will say, but had actually a longer wait time. Again, building up the courage, he had to contact and then had to wait for weeks and weeks was just, it's not okay. How do we get that down? What do we do? How do we support you as councillors and as officers to get that number down? Two more, sorry. But the other question is with regards to, I guess, the resident's journey when they try and get support. There's obviously lots of you on the call tonight, all offering same but different services. What do we say to a resident that says, I need to get in touch with a service, where do I go? And because for us to avoid that, directing them to the wrong place, and them having to be referred and repeat their story. So is there one number? Do they Google it? What do we tell them to Google? Who do they go to first? And then my last question, which is kind of the most worrying, was I've been contacted by a couple of residents who have said that they know somebody who's saying that they're a mental health professional and indeed like offering some counselling or support to people, but in actual fact they don't have any qualifications or training to offer the
Councillor Holloway, thank you very much, Councillor Holloway.
Sorry, I just wanted to ask, like, how do we protect?
Councillor Holloway, that is a dig at myself, Councillor Holloway, and I'm a mental health tutor. The Thurrock Mind would like to say, because they had me there for 15 years.
I don't know what you're talking about, but
I've received the emails that I was accidentally copied in on. So, and
I
also,
don't know what emails you're talking about, Councillor. I just wanted to ask, what do we do if residents are concerned, and how do we direct them?
Coming up to 9:12, can we move on, please, to the first few questions that Councillor Holloway issued?
Yeah, in terms of how many of our therapists are trained to deal with trauma, all of our CBT therapists who have more than 1 year in qualification, post-qualification experience, are trained in EMDR. The majority have also been trained in trauma-focused CBT. I'm sorry I haven't got the exact number who they here, but it is by far the majority of our CBT step 3 clinicians.
Great, that's really great, thank you.
Shall I comment about the referrals, if it's the wrong referral? And let's immediately hold our hands up. We don't always get it right. But all of our new transformation work that we're doing and a thread that goes across all of our services is that if you get a referral and it's not for you, is that you take the referral and you look at who you can pass it on to. So, and we don't always get that right. And sometimes our staff will bat it back. And so the experience of people is to go backwards and forwards, but it's something that we're trying to address. The other bit of it is as we develop, and Jane talked really coherently about the new primary care work that we're doing. A big key theme of that is a trusted assessor. So, i.e., that it's one assessment, and then that assessor will decide where it goes. It might not be for them, and that whichever other service in the system will trust that assessment. And if the assessment indicates it's for them, then they will accept that without any quibble or without any kind of challenge for the service user.
If I can just echo what was said there as well, EPUT and inclusion are working very, very well together in terms of through the positive pathway, passing people down.
Sorry, Robert, can I just cut in? I just wanted to suspend standing orders at the moment so we can extend the meeting. Has anyone got any objections? No. Thank you.
Right. Working together through reviewing patients' needs through the MDT meetings. So setting out what we found about the patient, why we don't think they're appropriate, or why they are saying they are appropriate for us, and the care is transferred in that way. That is working really, really well.
Councillor, can I just come in about the sort of single point of contact? I think that Councillor. So we're very lucky in Thurrock to have Thurrock First, which is our single point of contact for adult social care, for NELFT, and for EPUT. So that is open from 7 in the morning to 7 at night, open 7 days a week. And so people then can, that's not for crisis services, just to make that clear. There's a separate arrangement around crisis services and out of hours. But certainly if they weren't sure whether it was a physical health, mental health, or an adult social care service, we do have Thurrock First as our single point of contact that's integrated across all the 3 organisations.
Okay,
Great.
thank you all.
Thank you. And there's just one more question on the 37 days wait, like reducing that and also protecting residents as well from people that are unqualified for counsellors. Just 2 more questions, please, Chair, to be answered.
That's not actually a 37-day wait. They're seen and have an initial risk assessment and needs assessment within 2 weeks. We're normally at the moment we're booking within a week.
Oh,
so
great.
we're seeing individuals, providing some with, all receive a treatment at that initial point, agreeing their treatment plan. The majority then go on to a group Time for Change, which then helps them identify how the therapy will work, what they need to think about, what changes they need to bring about, and helps them prepare for the therapy. That's a 3-week course, and that happens after the initial assessment, and that helps them get ready for the ongoing treatment.
Great, that's really helpful to know. Thank you.
Thank you, Victoria. What I will say is that to bring up on your point regarding qualifications and stuff like that, obviously with, say, integrated therapies and recovery college, they offer tutoring, mental health tutoring. I don't know if Catherine Wilson could bring on some of the courses that you offer on that and the type of people you use to run those courses.
Yeah, thank you, Chair. I would appreciate just how to go back to the emails that have been sent to me. If someone wants to forward me a response to this or what they do with it because of the time, Chair, I'm very happy to do that. But just a response that I can reply to, because I don't know how this is dealt with.
Well, yeah, I mean, Chair, would you like to share those emails?
Yeah. Oh, well, I'll check with the resident. They're confidential, but yeah, very happy to share them. But with the officer to reply, of course. Who should I send those to? You can
send them to me as Chair of HOS.
I don't think that would be appropriate to share, Councillor, bearing in mind the residents. So I'm happy to receive a response from the correct
Roger or someone like that. You'd like to send
Catherine,
Yes.
are you going to come in there?
I was just going to say you could send them to me and I will deal with that and then give you a response.
All right, thank you. It'd be good to know how to deal with that. Thank you.
So yeah, Catherine, would you like to quickly just answer those questions regarding the courses that you run and who run them, the tutors?
I can't actually, because obviously I'm doing this on behalf of Lynn from Mind. We do commission. I know that Health Commission, but I think Robert would be able to tell you. Is that Robert? Could you say what courses there are?
Yeah, in the presentation, there's a list of the courses that we're currently running at the Recovery College. We also ran a number of sessions, both one-to-one and small groups, on how to use technology and how to get people confident with using technology to help them engage in therapy.
Thank you, Robert. Okay, with that, I say we welcome all your hard work, and we'll note the reports, and we'll welcome you to, if you want to go off and enjoy the rest of your evening. Thank you.
Thank you. Cheerio.
Cheers.
Thank you.
Okay, moving on. So now we are on item 10, Adult Safeguarding Annual Report. Can be found on page 93 to 120.
Sorry, Chair, we've got item 9 first. Ian Wake's COVID.
Oh, sorry, Ian. My mouse has slipped down. So yeah, Ian Wake, would you like to update us with your COVID report, please?
Thank you, Chair, and good evening. Let me just share my screen. I've tried to keep this brief, this meeting, because of the size of the agenda, but there's just a few slides in terms of the latest data and intelligence on COVID. This is the metric that certainly the media and perhaps the government obsess about quite a lot. So the 7-day rate of positive tests per 100,000 residents. I'm pleased to say Thurrock has consistently ranked towards the bottom of the list, and that's still the case. So we're currently, our overall rate is 127.3. That ranks us 106 out of 149 upper tier local authorities, so it puts us at about the 71st centile. The other good news is that's actually started to fall over the last week or so. So here are the historical rates and our historical ranking. So you can see compared to the peak, where we were nearing 160, that's fallen back quite a bit over the last week. We were concerned about the rate of positives per 100,000 in our population aged over 60, and there was some thinking from Public Health England and the Joint Biosecurity Centre that might move us up to tier 2, which we resisted. The reason we resisted it is because we could see from our local surveillance data that most of what was driving that, what was at quite a high rate, were tests in what's called Pillar 1. So these are tests that are undertaken in the hospital themselves or in care homes. And actually our rates were being driven by two things, outbreaks in Basin Hospital and a substantial outbreak in a care home that's now under control. And you can see that in the data. So from a peak of nearly 160 in Pillar 1, that's fallen right the way back down to 43.8. In terms of Pillar 2, which is positive tests in the community, that is rising, and that's perhaps the most concerning metric of anything in these slides at the moment. Although the absolute numbers are still relatively small, the majority, thankfully, of our positive cases are in young and middle-aged adults at the moment. There is clearly a concern at national level in terms of bed occupancy in hospitals and hospital admissions. So here's the COVID-19 bed occupancy at Basin Hospital over time. Again, you can see that has fallen back a little bit over the last week or so, but quite a steep rise from late September up until mid-October. The number of people in ITU in terms of mechanical ventilation is still thankfully quite small, but that has risen as well, from 2 on the 24th of October up to 9 today. These are all patients in Basin Hospital, so they're not necessarily Thurrock residents. One positive element in the data is it doesn't look like community transmission in Thurrock at the moment is a particularly big driver of demand on Basin Hospital. So we've managed to get this data from the hospital quite recently. So this shows the number of residents that come from Thurrock that tested positive for COVID-19 either on admission or within 2 days after admission. And you can see that actually the numbers are pretty low, and actually slightly lower this week than they were last week. So we know that certainly a proportion of that COVID bed use will be from people who acquire COVID within the hospital rather than within the community. It could be from admissions from other areas of Essex, or it could be, as I've said before, that a positive COVID test result is not necessarily the same as an infectious case. The tests can't distinguish between dead and live virus, and you can test positive for up to 90 days after becoming infectious. So it could be picking up residents that have gone in for something else and tested positive, but are not necessarily a COVID case. I think care homes remains my biggest concern. This is our highest risk area. We did have one quite significant outbreak, although I'm pleased to say that that's now very well controlled, but it's still sitting as an outbreak because the definition of outbreak, just by the national definition, is that it lasts for 28 days. But we are seeing more typically regular, what we're calling live exposures, so one case. These are generally in staff, and we're picking them up through our asymptomatic staff screening programme, and then managing to self-isolate them early. So just in conclusion, the Thurrock's overall rate of positive tests and ranking has fallen in the last 7 days, which is good news. Our Pillar 1 tests, so those tests in the over 60s that are in the hospital or care homes, have fallen substantially, although the rate in the community does continue to rise. Bed use has declined a little bit, but ITU has increased. Although you would kind of expect that, because ITU is a lagging indicator, so it will be reflective of the higher peak a week ago, I think. In terms of Thurrock residents who are testing positive for COVID, within 2 days of admission, that's actually fallen slightly from last week, and the overall numbers remain low. Care home outbreaks remain a concern. I think we've got a 4-week lockdown now, as colleagues and members will be aware. I think we need to use the time wisely. I think there are 3 key priorities that we need to focus on, although these aren't the only ones, and these certainly aren't the only things we're doing. But we need to really ramp up our enhanced measures for care homes. I attended the Care Home Hub, which is a group of professionals that meet 3 times a week. We had a really, really good discussion yesterday afternoon, and we've agreed some further measures in terms of refresher training and guidance on infection prevention and control, and a rolling programme of inspection. And I've recently put in additional enhanced testing arrangements for staff. We've been, as you know, testing all of our care home staff every week since about May, I think. We were one of the first local authorities in the country to do that. The NHS, in terms of clinical in-reach, I think has been a bit slower, but we're there or thereabouts. But there are additional testing facilities for NHS staff that may be going into care homes now in Thurrock. So every person entering the care home should be tested once a week to check they are negative. I think in terms of those who are extremely clinically vulnerable, again, the guidance has changed, actually, I think from yesterday, and been strengthened. So we need to concentrate our communications really to those residents in the highest risk groups, and those with underlying health conditions, those who are older, to try and get that community transmission rate down. And then I think contact tracing, we've got our own local contact tracing service. Again, not every local authority's got that. We were one of the earliest to be set up. I think that's worked really, really well, but it's certainly under strain at the moment as the numbers have increased. We are out to recruitment to expand the number of staff in that, and we are looking at trying to actually expand its reach and do something really innovative. So to do what's called level 2 contact tracing, to trace the contacts of contacts. And we're working on some proposals on that. And I'll stop there and take any questions.
Thank you, Ian. Councillor Holloway.
Thanks, Ian, for the detail. It's really, really appreciated. The care home situation still being a concern. Can you just elaborate a little bit more about? Obviously, I assume the concerns are that there's higher numbers than we would expect, and what are we doing to kind of dampen those concerns, really? Because I've had a couple of people contact. I feel like this level of COVID is getting closer to home, I would say, than the first wave, if that makes sense. I kind of know more people that have it or have been in contact with someone, and I do know a family member friend that's in one of the care homes who has contracted COVID. So it feels, as I say, closer. What are we doing to combat some of those worries about care homes?
So in terms of the risk, I will always be worried about care homes because they are the highest risk setting, no matter what we're doing, for two reasons. Firstly, they're a setting where it's very easy for the disease to spread because you've got people who are very susceptible to contracting it. And secondly, because if they do contract it, the outcomes are generally a lot poorer given their level of health and their level of acuity. So I don't want you to think that we should be more worried about care homes in Thurrock than anywhere else. And actually our rate of death in care homes, thankfully, and touching a large amount of wood, has remained one of the lowest in the country, and we're really proud of that. So I think our arrangements are working well. The care home hub meets 3 times a week. There are daily calls to care home managers. I think our PPE situation is well supplied. We have additional health arrangements in place in terms of additional health support and community gerontologist and a GP les. So a really good approach to care planning. I think so the debate we had yesterday was just human beings being human beings. As the epidemic progresses, you start with great intentions, but there's a danger that practice slips a bit in terms of strict adherence to infection prevention control. Again, I don't want the committee to think that we have a major issue with this in Thurrock, but I don't think it does any harm to continually reinforce that with additional training and support to our care home managers and staff, and just a program inspection to check that's in place.
Yeah, thank you. And Chair, if I have another question as well, that you saying about kind of the strictness, what should we do as councillors if I don't want to make this 1984, and I don't want to follow the government saying dob your neighbour in, because I think that's disgusting. But if you're aware of, especially ahead of big days like Halloween, like fireworks night, like Remembrance Sunday, if you become aware of events happening or people gathering, how best to deal with it? Should we contact you to get in touch with them, or like how do we deal with these things without invoking 1984?
I can assure you that many of your councillor colleagues are already in regular contact with me, reporting all sorts of things, or with our Thurrock Local Operations Centre. So I think in terms of how we would deal with it would depend on exactly what the breach was. So I often get reports of workplaces breaching. I think sometimes what people see in the reality isn't always the same. So in the latest report, there was a concern about a shop in Thurrock that had breached. When we investigate it, we would send our EHOs immediately down there. We do investigate them all. We found that actually that the contact tracing had been done absolutely perfectly, and that none of the other shop workers were contacts, and so there was no further action. So we would generally, I think it's a proportional response, isn't it? So in the first instance, you try and engage and educate. I think where there are venues that are breaching regularly, then we do have enforcement powers, and actually quite robust enforcement powers to close settings. Thankfully, we've never had to do that in Thurrock. I think people generally respond quite well to education, but we, without, as you say, wanting to turn into a police state, we'd always welcome intelligence. I think it's useful, and we will always act on it.
Okay, thank you. And that's everything. And I do feel very much, I'm sure the rest of the committee do, very reassured by your presentation, Ian, and your responses. Thank you so much for everything that you're doing, you and your team, and everybody always. Thank you.
Thank you for your kind words. It's an absolute pleasure.
Councillor Muldowney.
Thank you, Chair. Thank you, Ian, for keeping us informed. It is great to know what the local picture is, particularly as we go into this second lockdown. I just wondered if what was happening with Mayfield unit, because obviously they went over to be a COVID ward last time. I think some other wards at Thurrock Hospital. Are there any plans for that this time?
So yeah, that's a great question. So so you have to have what's called a kind of designated setting. So when you have people who are discharged from hospital who are still testing positive for COVID, what we absolutely must stop this ever happening again is them being discharged directly into care homes. So they need to be discharged into a designated setting that is CQC approved. We've actually taken the decision in Thurrock to use Oak House as a completely separate building and entity from any care home. So they would be discharged there, and they would continue a period of 14 days self-isolation until we were confident that they were no longer infectious before we would ever consider discharging them back into a care home.
If I can just add to that, Chair. So Mayfield Ward, as you know, was reopened, and it moved back from Brentwood Hospital. And there's been a lot of discussion with health partners about the number of disposition of beds. So Mayfield is not specifically a COVID ward. It takes people from Basildon Hospital who no longer need to be on an acute hospital site, but are not quite ready to move back home yet. So we've I think now got a good allocation of beds at Brentwood Hospital, Mayfield, and as Ian said, Oak House. We do keep that under regular review with health partners, and there are weekly calls. They're daily calls, in fact twice daily calls, just to assess the sort of escalation levels that we need to be at, make sure that there's that flow of patients out of the hospital. So Mayfield Ward is very much up and running on Thurrock Hospital site. It's not specifically a COVID ward, but it's taking patients who are not quite well enough to go back home yet, but don't need to be on an acute hospital site.
Great, thank you, Roger. That's good. Good. There's no chance of them going back to Brentwood. They're going to stay where they are they?
I think I'd never say never, because I think when Nell came and presented the report, they do need to make sure the critical thing will be about staff, and obviously people were moved on to Brentwood Hospital site largely to make sure that they maximise the use of specialist staff and equipment. There's no discussions at the moment about that. But I just think we're always looking to make sure that we've got the right number of beds in the right place and they can be properly and safely staffed. So there's no plans to do that at the moment, but I would be reluctant to ever say never.
Because presumably this second wave is hitting just as any immunity from the first wave of staff-wise may have worn off. Is that the...
Do you want me to answer that?
Yeah.
I mean, the immunity question, we're getting into some detailed clinical debate here, I think is an interesting one. The honest answer is no one is entirely 100% sure. Antibodies, immunity is conferred by antibodies. The levels do seem to drop after, certainly after 2 or 3 months. You can notice a drop, but antibodies aren't the only way that you can confer immunity in the body. So that there are the immune system is an enormously complicated system, and there are various mechanisms by which immunity can be conferred in terms of macrophages, T cell response as well. But I don't think anyone's entirely sure what the true level of immunity is in the population at the moment.
Thank you, Ian. Just quickly, Councillor Rigby.
Thank you, Chair. I'm just wondering what the rate of the contact tracing is in Thurrock, please.
When you say the rate, what exactly do you mean?
Success rate of contact, percentage of contacts, yeah.
Okay, so it depends on who's doing it, is the honest answer. So the tier 3 and tier 2, which is the national response, has, again, it varies obviously on a week by week basis, but it's about on average 60%. Where you come down to tier 1, which is the health protection team in conjunction with my team in specialist settings like care homes, for example, or schools, it's almost 100%, it's 98.5. We've also set up a local service that picks up all of the routine stuff that the national and regional teams are supposed to do, because we get that level of granularity data. So we call every single resident in Thurrock who's tested positive, no matter whether they've been contacted or not by the national team. And we offer support, we offer a welfare call, so we link them into things like the TCCA, because we believe that we'll get greater compliance. But we also, as part of that conversation, identify additional contacts. We've set up a Zansura database that cross-references the national data with all of our locally held data. And through our local knowledge in that database, that team's performing, again, at about 98%. It's dropped slightly, I have to say, over the last couple of weeks, just because numbers of contacts coming through and cases have gone up so much, which is why we're trying to recruit more staff. But it was identifying about 40% more contacts than the national team.
Thank you, Ian. Okay, thank you for that. Ian. I do feel as if we're stretching. There's only one of you, and we do seem to be trying to spread you everywhere at the moment. And I hope you do get a decent amount of sleep, because you do really need it and deserve it. You're working your fingers to the bones for us, and the same as Roger. I know you're constantly on call and answering all our questions. So it's a very testing time, and we won't be nowhere without both of you. And we really appreciate that.
Thank you very much. That's really kind of you.
Okay.
Chair, can I say that they've got other work to do as well, which comes on. We're always bothering them with other work, so it's just a thank you from me. Because I know I've bothered Roger quite a lot. But
thank you. It's what we're here for.
Okay, item 10. Thurrock Adult Safeguarding Board Annual Report. This report can be found on pages 93 to 120. Can I ask Jim Nicholson to introduce the report, please?
Thank you, Chair. And after the other excellent presentations, I have to say this is going to be quite a low-key presentation. I hope that's going to not disappoint too many people. The presentation is, there's 2 papers here, and I think in view of the time accepted, with your permission, I'll just speak to the first paper, the covering report, which picks up, I think, most of the key issues, and I'll do that at some speed. And that might mean that if councillors do have particular areas of interest or questions, they can focus on those to complete it. So the covering report, the executive summary, at the bottom of that, I know that councillors will be very familiar with the status of the Safeguarding Adult Boards under the Care Act of 2014, statutory body, and it has 3 core responsibilities. And at the bottom of the page, you will see that the first is to produce an annual report, which is what's before you this evening. Next, to produce a strategic plan. That's just been refreshed, a 3-year plan, and I believe that is going to be on the agenda of a early future meeting too, so I can come to that with some detail. And thirdly, to conduct safeguarding adult reviews. And again, I know that councillors will be very familiar with what these are about, and I'm very happy to report that we haven't had one in the year under review. In fact, we haven't had one at all. and we draw some grim comfort from that. But I would say we are extremely well prepared in the event of us eventually having to deal with one of those. Over the page, I explain how the CARE Act stipulates a number of activities, and in regard to the annual report, I'd just like to say some words about the strategic priorities for the year under review, and also some comments about performance too. So we had three priorities. The first was to implement a communication strategy, and again, that was completed in February of 2020. To implement a prevention strategy, that's preventing abuse and empowering communities to deal with that, and that was signed off in July last year. And the third one, which I would like to say a little about, is the understanding the scale of adult sexual exploitation and the gaps in transition. Transition is an area that hasn't perhaps had the attention it should have had, and we're looking very much to close that gap. That's with us and the Children's Services Partnership. And so we commissioned a report which was delayed because of COVID, sadly, by the London Metropolitan University. That's now been published. I would just say with some pride, it's actually gained national reputation for the quality of the report and for us taking on a subject matter that many people would feel some reluctance to do. So we're very proud of that. We've got a lot of work yet to do on that. And again, in the update on the strategic plan, which I hope to give in the near future, I'll be able to deal with that in some detail. Moving on now to paragraph 2.5, say something about the data from the previous year. And we have two key measurable areas, which are concerns and inquiries. And you will see that even though there was a falling off in concerns being reported, again through COVID, the year-end figures still represent a 20% increase on the previous year. We view that as a positive because in an area of great underreporting, we've put a lot of effort into establishing clear referral pathways, getting agencies fully aware of their obligations to bring these to notice. And then once we do have these concerns, they're all reviewed by our staff, and the decision to undertake Section 42 inquiries then made. And again, at paragraph 2.6, you will see there's been a substantial increase year on year of nearly 70%. And the co-author of this report, Fran Ledra, the principal social worker, is on the line as well, and she may be able to deal with any questions that come from the implications of that increase in workload. At the bottom of that page, at paragraph 2.7, we talk about the conversion rate. This really compares the numbers of concerns resulting in inquiries, and that has a figure which compares well with national averages. So I think we should feel some confidence that we're getting increased reports of cases, and they're genuine reports, and they are being actioned appropriately. And one thing that I'm particularly proud of is that in regard to the Making Safeguarding Personal agenda, paragraph 2.8, you will see a substantial increase in the number of people who, firstly, having had their desired outcomes identified and recorded, are finding those are being fully or even partially met. That I think is a significant improvement over recent years, and one that I think reflects very well on the senior managers of adult social care. And then looking forward, I put in some details about what we will be doing over the next year, and also, again, the strategic objectives within the refreshed strategic plan. Again, I could go through that now. I think maybe you'd want me to either pause here and take questions, because I can certainly come back to that at the next meeting of the committee. But in case I do forget, I wonder, with your consent, I could just flag up the actions we'll be undertaking as part of the National Safeguarding Adults Week. That's the 16th to the 22nd of November, so that's the week after next. And you will see, hopefully next week, a significant amount of information about how people can get involved in that to raise their awareness and also to participate in the agenda. I apologise if I've gabbled through that. I'm sorry if I have. I hope that hasn't upset too many people, but I'll pause here and take questions if I may.
No, thank you, James. No, it's a sort of very in-depth report, and it's quite an eye-opening report. no, the workload seems to be increasing. I know the way into managing that. I'll say it's a testing time as well. Everything is, I say, with the COVID situation coming on and how it's going to look in the future coming through on this system. Safeguarding obviously going to be one of our, it's always going to be one of our key things that we're on top of. I just do wonder, I'm looking at one of your case reports that you put in now, and it was about lessons learned. On the case report, you stated that you managed to stop a lady from being financially abused after 18 months. I do wonder, what have we learned from that? Is there signs there that training was put in place so we could spot it sooner than 18 months? And it was like £7,000 that are drawn from a bank. And I say, I know we always talk about safeguarding and more training, and I see the list of training that's been provided, which is very in depth. But when we have cases like this, what could we do to spot this abuse from happening sooner, highlighting it sooner?
Thank you. Yes, I think that's a very fair comment, and I accept that. I think some that might be. I was actually trying to get an update on both these case studies for this evening. I haven't been able to do it, I'm afraid. I accept what you're saying. I suppose, and maybe Fran might want to come in on this, but there is clearly a need for something to happen a bit sharper and faster on this stuff. The fact that these things were reported in the first instance is a positive, but the failure to deal faster with it is entirely a fair comment, and I think that's something that will be reflected. I think the actions that were taken were entirely appropriate and ended up with a good result eventually, and that will, I think, give staff confidence to actually progress that, because this is something that perhaps not many of them will have actually ever been involved with. So there's a bit of a confidence thing about even themselves getting enacting the opportunities to close down the abuse. So I think that's a positive. I accept fully that there could have been perhaps a faster response. It ended up with the right response, but I suppose that staff will now have increased confidence to action that faster.
Yeah, actually, that's what I was hoping you was going to tell me. What you've learned from me is to have the increased confidence to highlight concerns sooner. So yeah, fantastic. Councillor Wetzel.
Thank you. Hello, Jim. Very nice to see you. I just really wanted to ask you, Shane's actually pulled on some of my question that I was going to ask you, but it's not always the elderly, isn't it? Are we doing anything to help people with all the scams that are going on, with money that's being taken out of people's banks and pretend to be police or banks, and ringing up? I would have thought that the banks would have picked that up long before it got taken out of their bank, but I don't think that's happening at the moment. And I don't think some of these scams are getting through to people to know about it. Not enough perhaps literature's going out there. We rely too much on technology, and a lot of our residents aren't getting that, haven't got that technology anyway.
Thank you, Councillor. It's nice to see you again too. Yes, we do enjoy excellent connection with the police, who are one of the core members of the board anyway, and we have regular updates on that, and those are circulated. Of course, we know as well that there's national information being given to people to try and prevent these dreadful crimes, and I had two myself today, scam calls, so we're all getting them. I have to say that the police do invest an awful lot of effort into this. They do report these diligently to us, and with our own communication networks, we get that out as far as we possibly can. And in fact, in that National Safeguarding Week that's coming up that I just mentioned to the chair a moment ago, we do focus on that too. So if you have any contacts you think who would benefit from seeing that, please make sure they get pointed in that direction. I would just say finally that I was a police officer in my first career, and the level of interest and engagement now puts what I experienced to shame.
Yeah, obviously through you, Chair, do you find that there's good communication now with the police and officers and members you find there's a good, level of getting together, the communication's coming across.
Absolutely, both at county-wide level, and we had the chief inspector who has particular responsibility for safeguarding, who was on a conference call yesterday morning, even though he'd been performing night duty all the previous night. That's his commitment to it. But also at local level with officers within Thurrock, and indeed one of them, and I keep talking about the strategic plan that I'll be talking about, we have lead officers on each of those, and one of those is the local police commander, so they are fully engaged.
Good, thank you, Jim. Lovely.
Thank you, Councillor. Councillor Muldowney.
Thank you, Chair. Thank you, James. Is it James? Yes, just picking up on what Councillor Redsill was saying, because I've had an inquiry recently of somebody who was somebody perpetrated a fraud on them and got quite a lot of money from him. Does that get reported to the police and then the police report through to you, or would that be something that I could bring as a concern directly to yourselves?
Well, there is a body that does concentrate on fraud. My advice is always to report it directly to police, and then they can refer it on if they need to. When we get these cases, there are mechanisms to recover money, of course, that has been scammed, depending on how it's been accessed by the criminals. But yeah, my advice would always be to refer it directly to police in the first instance.
Sorry, I know this is probably not, this is more strategic, but in this case, it has been reported to the police, but there's been nothing further has been heard. It's been quite a long time now, which is why it's now come to me.
Well, I'm very happy. If you wanted to email me the details, I'd be very happy to take that on and try and get a response for your constituent. I think my details are on the report. If not, I'm sure Democratic Services can provide it for you.
Thank you. That would be great. Thank you very much.
Thank you, Councillor. There's no more questions. No. Thank you, James. Thank you for your report. As I have been noted, and I wish you the best and good luck, and I hope throughout this time you keep yourself well as looking after all the residents of Thurrock. Thank you so much.
That's very kind. I look forward to seeing you in the new year at the next meeting.
Thank you, Councillor. Thank you. Okay. I'm just looking and just talking with Jenny. The verbal updates. We're looking as if would members be willing to accept written updates, so we don't stay here till midnight. Yeah, is that fair enough?
Well, Chair, can I just say, if what was going to be in the finance fees and charges update, if this is this is the only thing we're getting on finance, is it?
I can more than happy ask Roger if you'd like to present that.
And also, I'm sorry, Chair, but the integrated medical centres and you were just talking about the verbal updates, aren't you? But yeah, I think it does need to be presented. I'm sorry that it's gone on this long, but it's not our fault that that's been the case.
No, Chair. So I was just waiting to not go to 11:30 like your last meeting. Okay. So moving on from that, we have the item 11, update of the hospital with the MICs. Roger, can I have an update for that, please?
So I'm just going to do a very, very brief update on the integrated medical centres, and then Tom Abel, who I hope is still on the call, is going to just do a short update on where we are with Dorset Hospital. So good progress is being made on the integrated medical centres. Corringham and Stamford Hope, which is the NELFT scheme, the contract has been awarded and the work will be starting on site. It may be impacted by the second lockdown, but if it doesn't happen this side of Christmas, it'll be starting very early in the new year. The progress on both the Purfleet IMC and the Tilbury and Chadwell IMC is progressing at pace after, again, a bit of a pause during the first lockdown. The design team is nearly concluded its work for Tilbury and Chadwell. We've got the commitment from the partners about the schedule of accommodation, the service that they wish to move in, The primary care elements have also now been concluded. We need to. There is a fairly, I have to say, quite tedious and bureaucratic process that we have to do to get NHS England to sign off some of this with multiple business cases that need to go through. But those, what's called the programme business case has now been signed off and is going through the machinery at NHS England. So we're still on course to have the other two open by the end of 2023. The one IMC that has most probably been impacted by COVID more than anything else is the Grays IMC that was going to be at Thurrock Hospital, and as the significant amount of that was around the moving services from Orsett Hospital, Tom has come here tonight to just give us an update on where we are with the move of the services from Orsett Hospital and where the plans are around Orsett. So I hope Tom is still on the call at this late hour, and I'll just hand over to him.
Yeah, I'm still here, Roger. Hi everyone. So in terms of where the PBC that Roger's just mentioned goes to our board this month, so it will go next week to go through kind of our approvals and governance processes in terms of the next steps. What happened during COVID is we did stop the service mapping at Orsett, and we haven't quite got to restart that yet. But what we have been doing is, I think probably people may be well aware, is that we've moved a significant amount of activity out of Basildon onto Orsett during COVID and are continuing to do that. Given that fairly substantial change in service, and given that that's in line with the direction of travel that I think we all want in terms of making sure that we're getting more services in place, we want to give that a couple of months to settle down, get the service mapping started in January, COVID permitting, and then we can then get the detailed plan for Grays drawn up. The date we're working towards for the final closure of Orsett is around 2025, we think, at this moment in time, to give enough time to get the Grays development up and running. Given that we've also got that, it means that we can make some decisions around what we need to do to make sure we keep Orsett up and running until 2025. But yes, I think it is taking slightly longer. COVID has not helped us at all with that. I think the positive thing to take away is, I think as a result of COVID, we will be moving more work than we originally envisaged out of Basildon Hospital into Grays as a result of this. And so, to give you an example, we've put in place a CT scanner currently now at Orsett, something we never had before. We've got funding for an MRI scanner, which we're looking to see if that's something that we can locate within the Thurrock locality or not. We've moved all of our day unit activity, so that's chemotherapy, anticoagulation services, things like that, have all moved to Orsett, and obviously we're doing significantly more outpatient work at Orsett than we did previous, and so all things that we wanted to happen, but obviously COVID's given us the opportunity to accelerate that. And I think we can see that kind of that the step towards Orsett is then a step towards then moving those services and that activity out into the integrated medical centres. And so that's where we're currently at. We're very much committed to making sure that we deliver all of the IMCs, and we'll continue working with all the partners in order to make that happen. And I can only apologise, it's taken us a little bit longer than we'd hoped to get the business case for Grays sorted out, which has been principally due to the fact that we've just been flat out dealing with COVID and then trying to get services restarted in the last few months. And so January is the kind of the date we really want to get moving again.
Thank you, Tom. Bringing in Councillor Mardoni first.
Thank you, Chair. Thank you, Tom. I mean, obviously, we appreciate that progress has been delayed by COVID, and I suppose, you know, it is disappointing from our point of view, but we probably can't say enough how grateful we are for everything that all of our NHS staff are doing at the moment, and the COVID response has to take priority, and obviously with Basildon as a COVID centre, You've got your hands full at the moment, so we do absolutely appreciate that. Can I say though, I don't think I looked through the minutes because I couldn't remember the last time we talked about this. I think it might have been March this year when we actually had the feedback from the task and finish group. And I completely appreciate that we haven't been able to move forward on what we resolved at that meeting, but I just don't want that to get lost, you know, with the decommissioning plan and everything. So if we can come back and look at that, I'm not sure about timescale, but I mean, Tom, perhaps you could give us an idea. I mean, obviously, you probably don't know. I understand the second wave might be worse than the first wave, but hopefully, sort of by the spring next year.
So I think we can definitely. I would suggest, I don't know if there is a meeting in January or not. I think January would be a good check-in point in terms of seeing where are we at in terms of getting the service mapping completed, and where are we at in terms of the planning around Grays in particular. We're not going to allow this decision to delay any of the others though, and so we are going to commit to the space taken in all of the other locations, and so that shouldn't delay any of the other IMCs. It's just the Grays one which I think may be slightly delayed as a result of these, as a result of COVID. So we want to make sure that we make good progress on the others whilst we do the more detailed work for Grays.
Great, that's fantastic. The only other query that I had was about this IMC phase 2. I mean, what is this about? There's IMC Integrated Medical Centres phase 2, and there's some talk about South Ockenden, but it then says this is not an IMC. So if it's not an IMC, then please can it not be included as a phase 2 IMC? Because what we're going to get is residents, and I know residents have spoken to some of us already, saying, oh, we're going to get an IMC in South Ockenden, and then it's not the case, and then you're just going to get annoyed and angry residents. So if there is going to be a phase 2, then that's great, that's all fine, but this just seems like it's going to be a refurb of an existing site. So let's not include it, please, if it's not actually going to be an IMC.
Shall I answer that, Chair? I think it's a little bit early to say whether it will or it won't at this stage. So most probably I was maybe jumping the gun. We are, as you know, we are looking to develop the Whiteacres site for our expanded and new residential care offer. There is a health centre on the same plot of land in South Ockenden, and we've had some preliminary discussions about relocating a couple of GP practices into there and expanding it into a whole, linking it into the Whiteacres development. So it may well be that might be confusing to call it an IMC phase 2, but it certainly has potential for us to develop a much wider primary care integrated health offer on that site. So we won't call it an IMC phase 2, but we're looking to see if we can develop that site in a much more exciting way for the people of South Ockenden.
Thank you, Councillor. I'd just like to ask, so I know I spoke to you, Roger, about this the other day, about the concerns with Grays, about how big it's going to be, what's going to be offering now. I don't know if you want to update the other members on that at all.
Well, I think Tom offered to come back, I think, in January, because I think they're looking now to most possibly, and this was always our aspiration, to see whether we could move more outpatients, more diagnostics off the Bowson site, because the Thurrock hospital site, I think, offers enormous opportunities. And I think, you know, with COVID and the desire to sort of have sort of more COVID secure sites is most probably, it's accelerated our thinking, I think, around that. So it may well be that we might want to bring some elements of the Grays IMC further faster, while some of that thinking and discussion is ongoing. But I think we might be better to have a more detailed report in January from the project team, Chair.
Thank you. And it's good to hear that we'll soon be seeing work taking place on the Coronum Hub.
Yeah, definitely.
Councillor Wetzel.
Thank you, Chair. Tom, I'm going to be a bit pedantic now and say most people listening to this will say Grays and they'll think of Grays, as they won't think of Thurrock Hospital, which is in Stiffer Clays and bordering on my ward. So it's just to back up on what you said a little while ago about more services coming into there. Obviously, the lockdown will stop a bit of that, but my worry is that there's not much parking in there. And I don't want to cause, obviously I've seen some of the plans for Thurrock Hospital and we've made sure that there's going to be parking in there. So I think to make, you know, we keep calling it Grays, and I think we've got to think it isn't actually in Grays, and people will think, oh, we're going to put something down in Grays, and we're not. You know, it is Thurrock Hospital in Long Lane. So what I don't want to see is too many things coming there before the planning's gone in, and we've got to make sure that we've got parking there, because it is a very awkward place to park, especially with the schools on the, you know, with what we've got in there now with the new schools. Thanks, Tom. I wasn't getting at you.
Thank you, Councillor. Yeah, I think, you know, COVID has thrown us a curveball with the lifespan of Allsip being extended for probably another year or so. So on that, I'll just bring in Councillor Holloway.
Thank you, Chair. My question's regarding, well, I'll actually firstly echo what Councillor Muldowney said, and just a huge thanks to everything that you're doing. And we do have an understanding that COVID has, you know, scuppered a lot of these plans, but we are desperately sad that it is kind of prolonging them for years, because residents are really anxious to see them. You know, they do talk about them a lot, they do mention them, so to have them delayed is really hard, but we do understand why. My question is, bearing in mind how the I'm going to say Thurrock Hospital after Councillor Redsall's intervention, but the Thurrock Hospital site now may look a bit different, bearing in mind all the service changes you've had during COVID. We did see plans for layout and did take a tour and saw the kind of buildings that they were going into. Will that considerably change? I'm just mindful of, it's good that this is a big site, but it's not a huge site. And will that be reconfigured properly so that it is a properly working site, not just everything dumped on there because we need the hospital closed by 2025?
So yes, so I think that's the importance of the service mapping, to make sure that we're very clear about what services need to be, and we're reviewing the site master plan as a result of that. And I think that's the reason that we do want to delay it, because I think that my fear would be if we rush it, given that we would be putting more services potentially in the location, then the new location, you know, and then the community hospital won't work. And so I think that's what we're saying is, give us time, let us, you know, do the service mapping, and so we're very clear about what the new mix of services is going to be. Let us properly review the master plan, and yes, it might be a year longer than we originally anticipated, but actually I think that will get us a much better outcome in terms of provision of services in the patch than if we just tried to, as you say, dump everything in there at an awful lot of speed, and then we have lots of problems with parking and access and other things like that, which obviously is something we want to avoid.
Yeah, we'll very much support, you know, taking a bit of time to get it right, but it must be right when it does happen, because obviously the anticipation and the wait has gone on for so much longer than we thought. So we'll support you in that as well. So thanks again, Tom.
Chair, could I just come in on that? Because there's at Thurrock Hospital, there's a lot of land out the back, but there's also a lot of businesses running from in there. You know, so that's what we've got to be careful of, that we don't put, as Councillor Holloway said, we don't put too much in there and then we cause a problem outside. You know, that's what I don't want to see. Thanks, Tom.
No problem.
Thank you, Councillor. Unfortunately, my internet has dropped out, so I'm using my mobile at the moment. It tends to happen with this work laptop. Okay, moving on. Do we want to do the verbal update for the London health checks? I know that Mark and Donald have been sitting waiting patiently. Would they want to send it out as a written one, or would they like to have time to do it verbally?
I'm happy to do it quickly if that's okay with you.
Yeah, that's fine.
So I'm Donald McGeechy. I'm a GP by background and medical director for the Joint Commissioning Team. I'm here because I'm also the clinical director for the Targeted Lung Health Check programme, which, as you have heard before, I think, goes across Thurrock and Luton. So I think the last time somebody spoke to you, there were plans afoot to start this programme in earnest in March and April of this year, but obviously it's been another victim of the pandemic, which means that it was delayed over the summer. As the summer went on, we started to make plans to begin in October, so that we would be starting to scan people end of October, beginning of November. And we've managed to get staff back on board who are now trained. We've had a last-minute glitch of the IT issues at Luton Hospital, because we are a joint programme with Luton. So it may be that it's going to be delayed until January. There's still a small chance that we'll start to scan people in Thurrock the first week in December for 2 weeks before having a break for Christmas. But the national programme, because of the pandemic, it has been extended now till the end of March 2024. So that makes it we should be able to fit it all in. I don't think there's, I mean, other than to say that although many things have been shut down during the pandemic, there's a very keen national priority to make sure that screening like this for lung cancer is not shut down, and that we should be making every effort to get it going again. And we certainly have been working hard to do that. But unfortunately, the IT demons have got in there. Still a small chance of starting in December, but probably starting now in January. So happy to take any questions.
Thank you, Donald. We was doing the scans, was it on the over 55s, wasn't it?
It's age 55 to 75, those who have ever smoked, and they would all have a risk assessment done to assess their risk of lung cancer. If they had a high risk of lung cancer, then as part of that risk assessment, then they would have a mobile CT scan, a low-dose CT scan, which will be based partly at Thurrock Hospital and other probably other supermarket sites around Thurrock.
Okay, and just one final question: are we still sort of not promoting but advising the use of vape instead of smoking? I know the NHS were doing a swap over sort of pack and all this sort of stuff.
I mean, it doesn't form part of this programme, other than that all of those who are existing smokers are part of this will be referred and recommended to go to the smoking cessation clinics. I don't know whether they are currently promoting vaping instead of smoking. Ian, you probably know.
Thank you, Donald. Thank you so much. Does anyone of the members have a question?
Do you want me to just answer that one, Councillor Ralph? So we're working very closely with this programme to integrate our own stop smoking services, and yes, vape is part of the offer. It's considerably safer than smoking, and it's been shown to.
I mean, so one of the drawbacks of the pandemic is that where initially the lung health checks were all done face to face, and there was the opportunity to move people straight into smoking cessation services, because it'll now be a telephone or virtual risk assessment and then the scan. It probably reduces the likelihood of getting through the smoking cessation services, unfortunately.
Thank you, Donald. Thank you, Ian. Okay, if we've got no other questions, do you want to move on to the verbal update?
Councillor Holloway's got a hand up, Councillor Ralph.
Unfortunately, since my reboot, I don't have any hands facility.
Okay, shall I just come in that case?
Yes, please, Councillor.
Okie doke. Two questions. Of course, like the reason we're in on this trial is because of the higher levels of lung cancer here in Thurrock. First question is, do we know if the prevalence of increased, kind of like further on stages of lung cancer has increased? Because obviously one of the symptoms maybe a cough, and are people being deterred from going to
Can I just ask you to start again? All I heard were 2 questions and then you dropped out.
Oh, okay, yes, of course. I'll try and make it shorter this time. One of the symptoms, obviously, of lung cancer can be a cough. That's also a symptom of COVID. Are people being deterred from coming in and being checked or confusing the symptoms? And has that resulted in an increased number of cases for us in Thurrock? And the second is, we had a difficulty with the number of GPs registering people who had, like, smokers or who had smoked in the past, and there was action to go out and get, you know, accurate numbers to get people tested. How many numbers of people have been registered now, and how many numbers of people have been screened? Are we still working with GPs to get that accurate data? Thanks.
First of all, the programme hasn't started yet, so we don't know what the effect of COVID will be in terms of those that will actually present and come forward. As far as your question about the numbers and the people, I think a lot of work's going on between the CCG, Public Health, to try and make that more accurate and make sure that with the right codes for people when you're withdrawing from the GP record. So we would hope that at this stage, where we're now doing the sort of extract before actually inviting people for the health checks, that it would be much more accurate than it was when somebody last talked to you.
Yeah, I think we keep getting, sorry to interrupt, but the reason we keep bringing this back, because I think this is the 3rd time it's come back, or maybe the 4th, and we do it as a verbal update, is that we are trying to keep a close track on that GP data and the numbers, because when it was first presented, we were told that, you know, estimations of the number of people that are smokers in Thurrock wasn't reflected in the GP data, and of course it will be also GPs that go out to their people. So the reason it's come back is because we want some accuracy and some understanding of have those figures got better.
So yes. Do you want to answer that there has been a huge push on this? I have to say largely before COVID, but I don't have the exact data in front of me, but from memory, we had got it up to about 95% coverage of smoking status recorded. So you're absolutely right to raise it, Councillor Holloway. And as you know, it was something I was concerned about, but I think we've largely cracked it now.
Great, brilliant. Then I can stop asking the chair to put it back on the work programme if we're confident that we're there now.
Yeah. There was a glitch at the beginning where I think because of a coding issue, a couple of the practices returned where it looked as if there were hardly any smokers, which obviously just wasn't true. So, but that has been looked into and it's been sorted.
Brilliant, great. That's all I wanted to know. Fantastic. Thanks all.
Thank you, Councillor Holloway. That's a great point raised. Thank you. Okay, is there any other questions at all?
So no more hands, Councillor, if you want to move on to Roger's update.
Yes. Okay, Roger, free to update us.
So this is an update on where we are with the fees and charges consultation. That is all this is. As you remember at the last committee, we I don't think you agreed, but the recommendation was that was agreed at Cabinet that we would go out to consultation on 3 options around our domiciliary care charges. That was to go up to the full amount of £17.05, a phased increase or no increase at all. We agreed with Healthwatch the process for the consultation, so there will be an 8-week period of the consultation that started on the 5th of October and runs up until the 12th of December. All of our dom care service users, obviously we have to manage this in a way that's COVID compliant, so we're doing it slightly differently than we have done in previous years, but we have written to every single one of of our service users. We have also put it on our the website, on our consultation portal. As of 2 days ago, we'd had over 120 responses already, and as I say, we've got another approximately 4 to 5 weeks of the consultation left. So for your January meeting, you'll get a result of that consultation coming back with the outcome of that, and then any recommendation then will go to Cabinet for its budget meeting in February. So I'll take any questions, Chair.
Councillor Holloway, do you want to come in?
Thank you for bringing me in, even though I don't have my hand up. I really appreciate it. I don't think I have got anything to say. Like, I thought it was supposed to be a wider financial update. It's not. We had the detail last month, so I don't think I have anything else to say on it.
Councillor,
Thank you, though.
would you, if you either send me an email or state exactly what you want us to bring to HOSC, we're willing to do it, to have a look at it.
I really appreciate that, Chair. I think that as I explained last month, the time might be out, because as cabinets, when we met in September, we were told that a financial update would go to cabinet in October. That financial update told us that the amount that we were going to have to save was approximately around 20 million. That meant, and then it was promised by cabinet that it would then come to scrutiny in November for us to comment on, to go back to cabinet in January, for this then all to agree it at full council. Because of the way of the timings of obviously cabinet and scrutiny, that hasn't happened, and I'm just curious about the detail. But I really appreciate that offer. I'll put it in an email. Thanks so much.
Thank you.
So no more hands, councillor. So it's on to the work programme.
Okay, brilliant. Okay, so we have on the work programme for January, I think the IMCs were going to come back. Is that correct? And give us an update now.
And I think you specifically asked for around the ORSIT timetable and a report back from the project team that is working on ORSIT and Thurrock Hospital IMC.
Yeah, so if we just ask for that particular update and not the whole full shebang again.
No, I mean, if we can touch on them if necessary, but the focus of the report will be the Thurrock Hospital one.
Okay, brilliant. I think, was that the other option?
Sorry, can I just make sure for absolute clarity that will refer back to the task and finish recommendations from the March meeting?
I'm sure it will, Councillor. I mean, obviously the thinking has moved on a little bit in the light of COVID, but we'll make sure it references back where it's still relevant. Yes.
Yeah, thank you.
Okay, thank you. So, okay, would we like to set this date to bring back, obviously, Basin Hospital in March? I think January may have a bit too soon for us to give us the information that we're really looking for.
Agreed.
Yeah, okay, great. We'll add that to the programme.
Yeah, thank you. Okay.
Okay, in that case, I feel that we're all done.
Thank you.
Thank you for the meeting, and it's now 10:26. And
Sorry.
Sorry.
The paper on the loan. The loan. We didn't put the loan on the work programme. Sorry.
Oh, yes.
I just saw it in my notes just as you were about to close. I apologise.
Right. We put a recommendation. I think we was going to communicate a letter together, wasn't we, to do that? So I guess we'll put that onto the work programme to give an update on that. Sorry.
Yeah. But wasn't Claire? Was it Claire Wheeler? Claire Wheeler coming.
Maria Wheeler,
Maria Wheeler.
Maria Wheeler,
the Chief Finance Officer for the CCG. I think it was her letter that we sent out in the last days. So we'll make sure that there is a written report for the next meeting in January.
Great, thank you.
Okay, thank you. Okay, good night, everybody.
Good night. Stay safe, everyone.